né? Aí, quando você puder, amanhã, outro dia, aí, passar.
Senhores, sou Ricardo Botelho e vou abrir o Congresso de Cirurgia Espinhal 2021. Quero dar as boas-vindas a todos. Bom dia, boa tarde, boa noite de vários cantos do mundo. Quero agradecer a todos os coordenadores, assessores, a comissão científica pelo trabalho que fizeram nesse evento. Quero agradecer ao professor Eberval Figueiredo, nosso presidente de honra e presidente da Sociedade Brasileira de Neurocirurgia. Quero agradecer fundamentalmente ao Dr. John Duff, Dr. Oscar L. Alves e Asdrubal Falavinha por ter possibilitado em que a Associação Americana e Europeia de Neurocirurgia e as suas sessões de coluna estivessem presentes nesse evento, o que torna muito mais grandioso. Muito obrigado a todos eles. Agradecimento à OSPINE, a Sociedade Brasileira de Coluna e a Sociedade Brasileira de Neurocirurgia, e o Departamento de Coluna da Sociedade Brasileira de Neurocirurgia, Dr. Milano e o Dr. Alessio. Agradecer a todos os palestrantes internacionais, aos 43, de 14 diferentes países, em tempos diferentes, por todo o esforço de estar aqui conosco no Brasil nesse momento. Muito obrigado. A todos os que estiveram conosco nos últimos 20 anos, produzindo esse congresso. Todos os brasileiros, todos os estrangeiros, que são a força desse evento. Pois não, Pedro? Eu quero agradecer a todos os expositores e patrocinadores que trouxeram as suas tecnologias, que estão disponíveis para que nós, cirurgiões, possamos ter o contato com as mesmas. Elas estão e ficarão na exposição virtual para que nós as possamos ver por um ano. Elas estão acessíveis para divulgar, para perguntar, para questionar. Sejam todos muito bem-vindos ao Cirurgia Espinhal 2021. Então, peço agora ao Dr. Oscar Alves, que tem a palavra.
Thank you, Ricardo. Dear friends and colleagues, in 2020, the world was suddenly struck by the SARS-CoV-2 pandemic, causing an economical and public health turmoil. And as you remember, Ricardo, in March, Espinhal was right in the eye of the hurricane. And although our last-minute effort, we could not keep the meeting, and we had to cancel this meeting going on for 20 years. And since then, and due to travel bans, all the on-site educational programs ceased. But this opened a window of opportunity to digital scientific meetings that Ricardo, as president of Espinhal, wisely embraced without hesitation. And here we have this version of the 2021. Once again, this year, I'm very grateful to Ricardo for giving me the honor to organize and design a pre-course congress, as we did it in 2019 with CSRS Europe. This time I challenged John Duff, chairman of the spine section of ANS, to join us. And he brought with him the most active and bright spine surgeons from Europe, a total of 21 people, surgeons, representing 14 countries. Certainly, this makes Espinhal nowadays one of the most complete and high-quality spine congresses in the world. So I hope that you enjoy the scientific program. I hope that the case scenario discussion and crossfires will inspire you on your daily practice. And I invite all the participants to raise questions and push the faculty against the wall. You have the Zoom chat and questions and answers to raise questions that someone will read for you. And I believe the success of today will enable us to meet in person next year and to appreciate the vibrant city of São Paulo. John?
Thank you, Oscar, and greetings everybody and good evening from Switzerland. It's a great pleasure for me to be here participating in this. We've talked about this for a while, and while it's now virtual, hopefully next time it'll be live. So once again, a big thanks to Ricardo and Oscar, especially the Brazilian Society for Spine Surgery, for having an ENS delegation. It's a great honor and pleasure for us. And I'd also like to thank my fellow speakers from the ENS who've all agreed to give up their time. And I think we have an excellent group of people, and I'm looking forward to a very high level and very productive series of discussions. So thank you again. I'm looking forward to it.
Thank you, John. So we'll go straight ahead to our first talking point. And the idea of this talking point is really to give an insight for our daily practice. And the first talking point, when to extend a lumbar fusion, either to thoracic spine or the sacrum, will be moderated by Claudius Tomé, which is a good friend from many years. Claudius is chairman of Neurosurgery at Innsbruck, is president of Austrian Neurosurgical Society, and the president of the training committee of ANS. Claudius?
Oscar, thanks a lot. Ricardo, Oscar, John, thanks for putting a great program together. I think I was told to keep the time, so I'll just go right ahead. And it's a great pleasure to invite the first two speakers, both of them very good friends of mine. And it's a pleasure to start with Enrico Tessitore from Geneva, Switzerland, who is heading the spine unit there at the university. And he, as Oscar already pointed out, is going to talk about the very practical and important questions nowadays in when to extend a lumbar fusion to the pelvis. Enrico, you want to start off, please?
Yes, thanks a lot. And thanks, Claudius, for the introduction. It's really a pleasure for me to be here with you, and I hope to see you next year in Brazil. And I thank, of course, the president of the Congress, Ricardo Boteo, and the coordinators of the ENS course, Oscar Alves and John Duff, for the invitation to talk about when to extend the fusion to the pelvis. Fusion ending to the sacrum might be associated with mechanical failure or pseudarthrosis, with a prevalence ranging from 3 up to 83% according to the data in literature, mainly related to the poor bone quality at the sacrum, especially in elderly patients, and to the substantial biomechanical stresses at the lumbosacro-pelvic junction. So it is not uncommon to observe hardware failure at the level of the sacrum in the form of rod fracture, screw fracture, or screw pull out. There are several risk factors which have been identified for mechanical failure at the level of the sacrum. The first is the persistent postoperative sagittal imbalance, which is a very hot topic, I would say, since now almost 20 years. The second is lack of anterior column support at the level of L5S1 disc. The third is the poor sacropelvic fixation. And last but not least, the older age. Before going to the indication to extend to the pelvis, I just want to summarize the pelvic fixation techniques. The Galveston rods have been abandoned, and nowadays we do have available the Chopin plates, as you can see in the middle of the picture, and two kinds of screws, which are the iliac bolts and the S2 LR screws, which are by far my favorite one. Why? Because the S2 LR screws are in line with the cephalad instrumentation. The screw heads are approximately 2 centimeters deeper compared with the iliac bolts. Cross connectors are not needed in most of the cases, and length of 80 up to 100 millimeters is achievable for the screws. The limitations of the technique include, first, the direct penetration of the sacroiliac joint, and second, that we don't know, honestly, which is the biomechanical consequence of crossing the joint. So there is pending biomechanical evaluation which is needed. This is how we do insert the S2 iliac screws. You all know this. The entry point is between the first and the second posterior sacral foramen. And then we do diverge in the direction of the joint. We cross the joint, and then we target the head of the femur here, going down and divergent. It seems that when we compare S2 iliac screws to iliac screws, the S2 iliac screws are associated with a lower reoperation rate, and reoperation are higher in iliac screws because of surgical site infections, wound descents, and symptomatic pelvic screw prominence. There is a reoperation rate calculated to be 8.6% for S2 iliac screws versus 35% for iliac bolts. And there is 14.5% of estimated absolute risk reduction for revision surgery by inserting S2 iliac screws. Now we come to the indication, in my opinion, to extend the fusion to the pelvis. And I tried to list them and to illustrate them by a few examples. The first indication is the neuromuscular spinal deformities. I'm not an expert on neuromuscular scoliosis, but here you may see a nice retrospective comparative study on children with neuromuscular scoliosis with constructs ending either to L5 or to the pelvis. And they showed that patients undergoing pelvic fixation had a greater correction of the major curve and of the pelvic obliquity, with the rate of complication staying the same. So they do recommend for all the children with neuromuscular scoliosis, especially when they do have coronal and sagittal imbalance in the pre-op, to extend the fixation to the pelvis. Multi-level segmental fusion surgery is a very common procedure in our daily practice. And it is defined being multi-level fusion surgery, a fusion concerning 4 or plus than 4 levels. Here, a nice study from the Vaikotzi group in Berlin, where they did compare patients undergoing to multi-level degenerative spine procedures, and they divided them in 3 groups. The first one with construct ending at S1, the second group ending at the ilium with iliac screws, and the third with the plate. So they found that the incidence of L5S1 pseudarthrosis seemed to be reduced by primary addition of iliac screws to a regular sacral fixation. They also found that the use of sacral iliac plate, like the Chopin plate, is associated with a higher incidence of other failure, like screw loosening or material complications, than the classic S1 iliac screw fixation. And even from the clinical point of view, they found that the clinical short and mid-term outcome was better when they used the S1 iliac screw fixation. The third indication is when we do apply or we do use long fusions or long fixation ending at S1 in osteoporotic patients. This is a case from Ibrahim Abaid where there is a TH11 down to S1 fusion. You might see on CT scan and MRI a new fracture, is insufficiency fracture of the sacrum, which required, of course, extension to the pelvis. This is a case from us with 3-level disc level fusion from L3 down to S1. And this lady presented few weeks after the fusion an insufficiency fracture at the sacrum with new onset pain, which required extension to the pelvis. Distal junction kyphosis and SI joint induced or accelerated degeneration is a common problem in spine surgery, especially if we do think about correction of scoliosis ending at the L5 level, and when we do not restore the sagittal balance, we might observe what we call distal junction kyphosis or DJF, distal junction failure, which may require extension to the pelvis. Here, a personal case with a lady operated 1 year before for L3 to S1 fusion for degenerative problems. And she came back with buttock pain and mechanical low back pain, which was related to screw loosening at the level of S1 and also an overloading of the sacral iliac joints as demonstrated by the SPECT CT scan. So we did extend the fusion from L2 down to the pelvis with a clear improvement of the symptoms, especially the mechanical back pain. Then if we correct spinal deformities and we need to end to S1 as a lower instrumental vertebra, so there is, in my opinion, an indication to extend to the pelvis. If you look at this paper published from Yasuda in 2016, they were able to compare two groups of patients undergoing multi-level segmental lumbar fusion, the iliac group and the non-iliac group, with 6 patients ending with construct ending at L5 and 19 patients ending S1. They did find a higher complication rate in the non-iliac group, and for the construct ending L5, it was mainly L5 S1 induced and accelerated disc degeneration, and for the construct at S1, they did find more screw failure and pseudarthrosis. In the iliac group, they define this as being a more invasive surgery, but they had lower complication rate. This is a case operated elsewhere for a 1-level PLIF surgery a few years before, and she came to our observation because of a degen scoliosis, a slight obliquity of L5, and a mechanical back pain. If you look at the full spine EOS, she was slightly imbalanced on the sagittal and as well as on the coronal with scoliotic curves, minor scoliotic curves. We decided to operate these patients again from L2 down to the pelvis, because in our opinion, handing to S1 was not a good idea, and we would like to restore the obliquity and the parallelism at the level of F5. If you might see in the postoperative EOS on the coronal cuts, here you may see the restoration of the parallelism at F5 by using an ALIF surgery and extension to the pelvis. The last indication, in my opinion, to extend to the pelvis is whenever there is an insufficient or impossible S1 fixation because of a tumor or fractures. In our daily practice, we do extend to the fusion, to the pelvis, fusions in case of spinopelvic dissociation, especially for those sacral and pelvic fracture with a line of fracture going medial to the facet joint or through the facet joint F5S1, then there is no place for S1 screw. In this case, there is an indication, in our opinion, to go down to the pelvis. So I'd like to thank you for your attention. I'm very happy to answer to your questions.
Thanks a lot, Enrico. I think we'll go straight ahead and have the questions then at the discussion section after Jesus' talk. So we'll do that, but I'm happy that everything worked, and thanks for the technical support that this is running smoothly. I would also encourage the audience already to put questions in the Q&A of the Zoom meeting, so we'll be able to discuss all together once Jesus has finished his talk. So now it's a great honor to introduce Jesus Lafuente from Barcelona, who has been the ENS president, is past president of our society, and obviously very much involved in ENS activities and in spine and with many meetings. It's a great pleasure to ask Jesus to give his talk. Now he will talk on the upper end. He'll talk about when to cross the thoracolumbar junction in your fusion surgeries. So please, Jesus, you have the floor.
Thank you very much, Claudius. Thank you to all the organizers for at least getting us all here, even in a virtual situation. I was in the Brazilian meeting before, and I'm happy to join in again from Barcelona nowadays. Anyway, thank you so much for the invitation, Oscar and John from the spine section, and Claudius for moderating, and also to the president of the Congress who has kindly invited me to this. So yes, I'm going to start with when to cross the TL junction. Another topic, we saw Enrico's beautiful talk about how to do it from the bottom side and go in the indications. And we know that the basic functions of the spine are those of support, protection, the neural elements, and also motion. But it's important to know about the curves, the kyphosis, and the lordosis that spine sections have to provide a mechanical balance that allow us to move and to do all these extreme movements that we can be able to do on a rigid spine. When we talk to indications for crossing, I would like to mention adult degenerative scoliosis as the most important one in this situation, or when previously failed lumbar fusions have occurred. Also happens when you do idiopathic scoliosis. This is not one of my fields of expertise, double curve scoliosis and other deformities. And I think in these situations, the construct tend to be smaller and shorter because of the spine being very flexible. As we all know, in younger adults, the scoliosis is driven by coronal deformity. Shorter constructs allow, because of the elasticity of the spine, whereas in the older adults, scoliosis is driven by pain, disability, and this is what we find on them. We can see osteoporosis as many patients. There's a higher stiffness, which means that keeping the curve maintained is difficult. That's why we need more anchoring. It is difficult to fuse, and we have problems with fusion. Also because of the worse nutritional status. All these are concepts that we have to take into account when treating adult degenerative scoliosis, which makes it a very big challenge compared to other deformities. So we all know what the objectives of surgery are, is to correct deformity, solid spinal fusion, and very important, more important, as we get on to this pathology more and more experience, is to achieve sagittal coronal balance, maintaining the curves. This obviously is technically demanding. This is a large exposure of wound, which increases the risk of infection, high blood loss, long hours, particularly if you also incorporate anterior support for this type of correction. These are the 6 levels of operative treatment according to the Lenke-Silva classification, and you can see 5 and 6 talk about transpassing the thoracic spine. And we know that thoracolumbar junction remains a surgical challenge, that if we might minimize the risks. And for that, it's important to choose the right patient, also to analyze the spine-pelvic harmony, and this is crucial, and we've been seeing by what Enrico was mentioning also in his talk, and this has become like the most important issue when operating complex spine constructs. We need to look for relevant comorbidities as well. Osteoporosis might mean that we need to cement our arthrodesis, and also neurological disorders. This can limit what is worth for us doing as an operation. So why is keeping the spinopelvic parameters right, the sagittal balance, not only allow us the best conditions for fusion, as there's no pressure or no forward bending, but also allow us to preservation of the adjacent segments. And Chen, in his article, talks to us how to match the lumbar lordosis, which is crucial in this manner, with the pelvic incidence. And we all know that patients who are bent forward with time, we activate the compensatory mechanisms, which include thoracic kyphosis, pelvic retroversion, and finally hip and joint positioning. And when these compensatory mechanisms fail, we need to operate these patients sometimes. However, when the pelvic incidence is low, the compensatory mechanisms will fail quicker and faster. Whereas if the pelvic incidence is very high, the amount of surgery required to compensate that curve is more demanding. So as a rule of thumb, the goals are in those patients with a pelvic incidence of less than 35, a lumbar lordosis post-surgically would be allowed or acceptable if you increase up to 10 degrees, where the pelvic incidence is between 35 and 50 is the same. And when the pelvic incidence is 50 to 80, we can allow the 10 degrees less on the lumbar lordosis. But if we're going to cross the thoracolumbar, when do we stop? Because the thoracic spine is very long. It's got, as you know, 12 vertebrae, and we need to decide if we go lower or we go higher, or where do we stop? And most studies have shown that when you stop in the lower thoracic spine as your upper instrumental vertebra, they have much more PJK than if you go higher up to T3 or T4, although some of the papers tell you differently. But the modes of failure differ. When you go to lower thoracic, it's a fracture which normally occurs, and this is because you didn't maintain the curve, you didn't keep the sagittal balance, and the force at that level is too much. And when you go upper in the thoracic T3, T4, you will find that the complication more classical is disruption of subluxation, in many occasions with neurological deficit. So to resume, lower T10 to 11, whenever we think the curve can be maintained, even acting anteriorly through lumbar or lateral interbody fusions or cages of any sort. However, if you don't think this is going to happen, or you have a double curve, or you have idiopathic scoliosis, which typically occurs in the thoracic spine, you have to be going to higher levels, T3, T4. It's not recommended never to go in between T5 and T8. Some special cases on idiopathic scoliosis you might, but not as the apex could fail more than if you go on the upper or the lower side. And T12, you should never cross it. This is a case that was sent to us by another hospital. This lady of 78 years of age has had 6 operations in the last 10 years in this same center. The last operation she had, as you can see, she was fused up to T12, and she came to us paraparetic severely with a grade 1 or 2, with a huge herniated T11 to T12 herniated disc. And at this time, we didn't know if we should go anchored to T10, but because she was bent over and we were not prepared to do a PCO on her, because as you can see, flat back, but she's probably not going to be able to be mobilized. Then we decided to plan and do a longer construct at the T3. And this is what we did, as well as removing the disc through the through a costotransectomy on the right. So this paper is from 2007, and there was not mentioned the uses, the evaluation of the spinopelvic parameters. And you can see they divided the 125 patients with a 2-year follow-up in between ending at T9, T10, T11, T12, and below the thoracic junction. And you can see that the PJK was higher on the lower thoracic, because maybe the stress given on the above vertebrae is higher, but the revision rate was higher when you didn't cross the thoracolumbar junction. We also saw this meta-analysis by Fan, who looked at 22 studies with more than 15 patients on each study, over 783 patients, comparing short fusions versus long fusions, And when I say short fusions, I mean lower thoracic versus higher thoracic. And they show that the complication rate was similar, as well as the outcome measures. But so other formulas have been seen to try and go short. We tend to go short if we can, because that means you don't have to do such extensive surgeries. And they've been looking to other things. One of the other things I've been looking is at the upper instrumental angle, which is taken by the lower end plate of the upper instrumental vertebra, and run an angle with the horizontal plane. And if this angle is more than 15 degrees, has a higher chance of fracture. And these fractures occur between the first 8 weeks after surgery. So if you do through the operation and you can see there's a big angle there, you should think twice or maybe go higher. What are the causes for failure? Well, having to resist excessive tension to hold the achieved correction is one of them, of course. But also, very importantly, is badly positioned instrumentation, who are basically not doing the job properly. Laminar hooks and the excessive tension can also cause pseudarthrosis, and excessive tension in the rods means that the rods can be broken down, and that's why we tend to use now double rods in the most where the curve is most the obtained the better curve. To be honest, the causes for failure for me is about decision making. Maintaining the curve is mandatory, and you don't decide properly if the upper or the lower instrumental vertebra is, you may have these problems. This is another patient that came to us. This is a short construct, and maybe this is a criticism of me. It's a 50-year-old lady, young lady, operated for lumbar pain and right-sided sciatica. And she stayed well only for a few months, but much worse over the last year, and was unable to work, incapacitating pain. We thought that we should sort a short construct a bit higher. She had the L2, L3 disc a bit touched, and I thought by doing this, it could be enough. So we prepared this construct. We corrected slightly the sagittal imbalance. You can see that the lumbar lordosis is good. Now she comes back with more pain than she had before, and now we are thinking what else to do, because the lordosis is maintained, but the coronal double curve is probably determining that she has continuous pain. So we need to look to these patients with special eyes, because it's not very easy. So what are the other solutions that many authors have shown? And this is a very interesting paper from Shaffrey Group, where they use the junctional tethers. They believe that the upper instrumental vertebra can be under tension, and the vertebrae immediately above them also even more tension. So they put some forms of wires called tethers or polyethylene, and they put them onto the crosslink, as you can see in the picture. And they've shown that in these patients, those who have PJK, in a group of patients, 120 patients, those who had PJK had, the tethered bands had less PJK than those who didn't. And this was nearly statistically significant. So they have demonstrated that this is an alternative to improve the shorter thoracic crossing. Also, they talk about another paper in China. This is about the anatomy trajectory. They call straightforward an anatomy trajectories. The straightforward is very close to the end plate, and the anatomy is inside the bone, that you can see in picture C compared to picture A, and B is a mixture. So the upper instrumental vertebra have one screw more anatomical, one more straightforward, and they have demonstrated with certain amount of patients that those with the straightforward screws have less PJK than those with an anatomical one. So perhaps also thinking how to put the screws in the upper instrumental vertebra is another good point to take into account. So to minimize failure, we have to decide in not too much, but also not too little. But we have to maintain the good spenipelvic parameters. And I will emphasize this because I think nowadays this is the key to a successful operation. Also anterior support and bone grafting. And this is a paper from the International Spastic Group who showed that with lumbar or lateral interbody fusion and cages, the support and the parameters, lumbopelvic parameters and SBA improved dramatically compared to those who had only posterior fusions, but this didn't came with major complications, more leg weakness, greater blood loss, and longer operative time and hospital stays. Another of the options that some of the authors advocate is on those vertebrae above the upper instrumental vertebra, lower thoracic typically, that you think they will be suffering pressure. Then you cement the last vertebra instrumented plus the vertebra above, and they have shown also in these patients to have less adjacent segment degeneration than those with no cemented vertebrae. So we all know the causes for PJK, and I'm not going to go because time is running. But I like also to mention that the musculature is very important once we see those patients who, for some reason, they go and bend forward lately. So you see, and they have been discussing of proximal junction angle. You see in pre-op, the angle is in one side with bending forward dramatically, and SVA very, very high indeed. When you reduce by osteotomies or reducing or putting cages, reduce the SVA dramatically, the angle changes, but maybe perhaps due to muscle, age, and many other comorbidity control, bad surgical technique initially, these patients tend to bend forward slightly with time, and this has to be minimized through choosing appropriate upper instrumental vertebra, looking at the spinopelvic parameters, fusing anterior column as well as posterior column in many patients, and so forth. This is a graph that I like to see.
2 minutes to
I'm just finishing. Yes, this is the last slide. I just want to put this graph. This between confidence that we have when we start and with zero experience. And this is a curve that you start having the complications, reducing and learning and having experience. We want to think that we are here, but nobody can tell us if we are not there. I think spinal complex surgery is like a dance of valse. If you do the right steps, this is a beautiful operation, but you have to match them all in. And to conclude, if you want to go low in the thoracic spine, you should do it at T10 to T12. If you want to go high, T3 to T4. I would not recommend going to the kyphotic apex. They have much more complications. Beware if you go too little or too short, because you may have to do more operations. Beware if you do too much, because you might have more complications. Tailor-made is best. Experience is mandatory. Use spinal centers for this. The main surgical skill remains knowing how to get it right. Not too much, but certainly not too little. Use the spinopelvic upright x-rays. And remember that no one has a magic wand. Thank you very much. Sorry for the rich.
Thank you very much, Enrico and Jesus, for this talk. I think we'll probably only have a couple of minutes.
Until you can go until 45.
Okay.
Seven
then
minutes.
I don't see any questions yet, but I actually have at least one question for each of you. I'll start with Enrico. Enrico, you told us that obviously going to the ilium will enhance the strength of your construct, and you will have less mechanical complications. But people argue that there are also negative effects of going to the iliac. Like SI joint pain, and particularly your case where you actually treated SI joint pain after a fusion by putting a screw in there. So what is the data and what is your experience on SI joint pain after putting iliac screws?
Thanks for the question, Claudius. I would say that in my personal experience, I did a few cases where the pain came directly after surgery by crossing the joint, but I had few cases where the prominence of the screws, especially when the sacrum is with a very high pelvic incidence, so it's quite horizontal, and so the head of the screw is not that deep as we would like to have it. So I had some problem with the screw prominency. But I would say that it's difficult nowadays to demonstrate where the pain comes from. If you come from the fact that you crossing the screw, the joint, or because you are anyway preparing the superiosteal way this part and detaching all the muscles. So this is quite invasive. That's why I moved from iliac bolts to the closer to the midline. with the S2 LR screws in order to avoid all this muscle preparation, lateral subperiosteal preparation, which is, in my opinion, very painful, and also is prone to have a higher prominency of the screws. So even though we don't have evidence that crossing the joint is uneventful, I still convinced that this is the best way to go.
So you're quite liberal with that. Just one quick question, quick answer maybe. What about put cement augmentation for your S1 screws, and what about S2 screws? Because some people argue that this would also be an easy alternative for stronger lower fixation, and you may not need iliac screws.
I didn't mention this option. I also had some cases where S1 screw failed during the surgery, and so I put some LR screws, or I put some S2, or with or without cement. The problem, as you know, that the spongosa of the sacrum, especially in elderly sick patients, is very poor, and so even the cement does lots of sort of balls bilaterally. The anchor of the cement in the spongosa is very poor at the sacral level, so that's why I do not prefer to insert cement in the S2 LR screws.
Okay, perfect, thanks. Jesus, the upper end. Maybe one question. You're also a big MIS guy. So what about, people argue, because you said musculature is very important, and we found out that some people that have poor musculature, or Parkinson patients that have a neurologic disease in addition, they fail much more commonly the upper end of the construct. So what about doing it MIS or through the muscle to have less muscle damage and to avoid PJK by doing that? Is that something you do, or hybrid cases, or? You're still muted.
Can I ask quickly, going to the first question, the second question you made to Enrico, I would like to say that it's dangerous to put cement on the S2 screws. You never know where the cement will go. And if you go into the pelvis, you can have a big disaster there. So for those who are thinking it's a good solution, it is definitely not. It hasn't happened to me, but I've seen a few disasters in some of the patients that on that respect. With respect to the question, absolutely agree with you. And the patient I did show was done with my colleague orthopedic surgeon. He's not very keen on MIS, but I proposed on that patient, on the T12, to do hybrid, because we can now connect through connectors to the old rods. You can open, if you want, to the middle with the skin, but certainly you open slightly through slits through the fascia, preserving all the musculature. You can go from lower lumbar to higher thoracic with no problems, and attach that rod with a connector to previous rod if you want to do a connection between those. To have a initial flexion, from lumbar to thoracic, you have to double curve your rod, and to do it all minimally invasive is difficult and challenging, but and this goes with sacrifice of the lumbar lordosis. And at this point, I believe that maintaining the sagittal balance with good lordosis is mandatory and goes in front of the surgical technique you want to decide.
Mm-hmm. One question, you didn't talk about the material. You just said you were double rodding in the middle where you had your most prominent maneuver or whatever. What about titanium versus cobalt chrome?
Cobalt chrome, always.
For all your long-standing constructs.
For all my old, yes.
Okay. Because actually we stopped doing that. We are now doing what we do now, doing double rodding in the middle, for example, at the PSO. And we use only titanium because we feel like this would be more a soft landing. No data on this, but we feel that it may have less rigid.
Okay, guys, very, very nice discussion. Thank you, Jesus, Enrique.
I'll tell you later.
We need to move on. And please.
Okay, thank you. Thank you, guys.
Oscar, are you going to have the device and technology, or we can move on?
Yes, please, device technology, yeah.
Bonalive, substituto ósseo de vidro bioativo S53P4 com efeito bacteriostático de longa duração, proporcionando uma neoformação óssea rápida e adequada. Gentacol, esponja de colágeno hemostática com proteção antibiótica de gentamicina. Gentafoil, película de colágeno antiaderente com proteção antibiótica de gentamicina. Avitus, coletor de osso autólogo e sangue medular minimamente invasivo. Ossis Medical, tecnologia aliada à regeneração.
Okay, so we are back to our second talking point, and really appreciate the first very insightful lectures of Enrico and Jesus. And now regarding talking point number 2, it's centered on how the different pelvic incidents can influence the choice of your interbody fusion in lumbar spine. So the moderators of this session will be Enrico Tessitori from Geneva, Switzerland, and our friend from Brazil, Alessio Barcelos. Please, go ahead.
Thank you. So our next speaker will be Dr. Bart Depreté. He's neurosurgeon at the University of Hostel-Leuven in Belgium, and he leads the multidisciplinary spine program. He's the secretary of the Belgian Society of Neurosurgery and also the secretary of the Belgian Spine Society and a member of the spine section of the EANS. So his talk will be about transforaminal interbody fusion for normal pelvic incidents. Please, Professor.
Okay, thank you, dear Chairman, dear gentlemen. Let me share my presentation. Can you all see my presentation now?
Not yet.
Not yet.
Now, yes.
Yes.
Just put on screen mode, please. Yeah, perfect.
Okay, there's some delay apparently from Belgium. Anyhow, so thanks for the invitation, and my talk will be on TLIF and its relation with pelvic incidents. So the characteristics of the TLIF procedure, as everybody probably very well knows it, is that you remove one facet joint to get access to the foraminal zone, to the disc there, and to put in your cage through that route. And the advantages are that you have less retraction on the thecal sac. There is some retraction, but at least less than in a PLIF procedure. You get a full decompression of that ipsilateral exiting nerve root, which can be important. And there are several cage options you can choose. You can choose a so-called banana cage to put in anterior in the intervertebral space. You can put in a diagonal case, and you can even put in, as you see in the axial CT scan image, several cases which you put in, and then with a walker you put the cage aside, and you can put in an additional cage, and you could put in up to 3 cages that way, and have a quite good footprint for fusion. One of the main advantages, I personally think, is that you keep the option of fusing the contralateral facet joint, which stays intact in that procedure. You don't remove it, and so you can drill out the joint itself and then put in bone grafts there. And as you see in the second axial CT scan images, that gives a very good option to fuse there as well. And then finally, it's a very easy and elegant procedure, open to minimally invasive surgery. And by doing that, you can nicely reduce an anterolisthesis, for instance, as you see in this case, or you can optimize and restore lordosis that is lost by very well getting your cages anteriorly and applying compression on the pedicle screws, as you see in these images. And obviously, you should avoid to lose any lordosis, and it's something we got used to and we pay a lot of attention to when we develop the strategy for our fusion. As you see in this case, this was a lady with a grade 2 endolisthesis at L5S1. And it was not very well reduced. Actually, it was not reduced at all. And there was a very significant loss of lordosis at L4, L5. This is certainly not what you should do. And with a TLIF, you can avoid this. It's just not paying attention to it. It's been investigated and published actually that the higher the grade of lordosis is at, for instance, L4, L5, if you don't pay attention, the higher the rate of loss of lordosis is there. So this is certainly something you should avoid when doing this kind of procedures. And this brings us to the point of pelvic incidence and sagittal alignment. And just to quickly set the scene, the pelvic incidence is the angle between the mid-perpendicular line to the sacral end plate on the one hand, and then the midpoint of the sacral end plate to the middle of the femoral head on the other hand. That's the pelvic incidence. It's specific to a person, to an individual, and so it doesn't change in different positions, as opposed to anteversion of or retroversion of the pelvis, which will lead to a different pelvic tilt and sacral slope. The sacral slope is the angle between the sacral end plate on the one hand and the horizontal plane on the other hand, and the pelvic tilt is the angle between the vertical line and that line that connects the midpoint of the sacral end plate with the middle of the femoral head, as already said. And when you add the pelvic tilt to the sacral slope, then you get pelvic incidence. And I said the pelvic incidence is constant, and as it appeared throughout studies and has been published by the French school, depending on the magnitude of the pelvic incidence, you have different types of curvatures of spinal alignment. And so there is a strong association between the ideal lordosis for a certain person, for a certain individual, and his pelvic incidence. And Lueck calculated in a large statistical series that ideal lumbar lordosis is half of the pelvic incidence plus 28 degrees. So the question is, by doing a TLIF procedure, can we actually get an additional lordosis? Can we introduce additional lordosis to get to that ideal lumbar lordosis? And specific gauges have been developed with sharp angles or even expandable gauges. However, in series that have been published, the gain you get by putting in a cage like that and overcorrect is actually quite disappointing. And as you see on the top tables for different types of fusions, you see that the higher, the more anterior you get your cage, the higher the change in segmental lordosis will be. On the left hand. On the right hand, you see that different magnitudes of lordosis of the cages actually do not make any difference between the change in segmental lordosis you will achieve. And that's also true for TLIF, as you see at the bottom there. So you see that several angles were used in several numbers of patients, and you see that it doesn't really make a difference. On the contrary, the gain was actually higher with the lower angle cages. And so the question is, why is that? Why is the gain of lordosis limited for a TLIF procedure? So first of all, it's because of the posterior introduction of the cage through a craniocaudal small space you have there. And so you will overstretch those structures to get in the cage. And that's not really the main problem. The main problem will be that the anterior longitudinal ligament will restrict the stretching you can get. So the additional correction will be particularly limited by the anterior longitudinal ligament, which remains totally intact in a TLIF procedure. You have no option, no possibility to get to the anterior ligament. And then finally, and also very importantly, is the nerve root anatomy. The cranial caudal distance between the exiting nerve roots actually gets lower the lower you get in the spine. So for instance, between L1 and L2, the distance is higher than between the L5 and S1 root. So it will be difficult to get a very high cage in there between the L5 and S1 roots without the risk of potential damage to a nerve root. So meaning that the points that I address here are particularly valid for L5S1. And the higher you get in the lumbar space, the higher your possibilities are to get in a higher cage and to try some overcorrection. But the lower you get, the lower your possibilities are. And so if you really want to get an additional gain in lumbar lordosis at L5S1, an A-lift procedure would be a better option. And that brings me to some additional considerations. So talking about the ideal lumbar lordosis in the spine, we have to realize that that whole concept has been developed on standing X-rays of the full spine. And for instance, in a sitting position, the ideal lordosis that is associated with a certain pelvic incidence is about half that angle you get in a standing position. So meaning that you could get a perfect alignment in a standing position, and the person will functionally not necessarily be better or be totally comfortable in a sitting position, and also associated or the angles associated, the alignments associated with other types of positions are also different. So that's something we should realize. And that's in a static posture. When you apply that on a walking or moving spine, then it becomes totally different. And that is still a field of ongoing research in gait analysis for walking. But we have to realize also in exercising, in working, in fighting, for instance, as you see these skeletons do here, that the alignment actually is not necessarily the ideal alignment you get in a standing static posture, as the whole sagittal balance concept tells us. So it's something more intuitive, I think, in real life. Also, neurology is important, and you can get a perfect alignment and be very glad with the postoperative X-ray of your patient. But if you did damage a nerve root to get there, that effect will have a major influence on the functionality of your patient and on his or her quality of life. So the effect of neurological injury will actually be larger than a suboptimal sagittal balance. It's also something to take into account. So to conclude, with a TLIF procedure, you can optimize your lumbar lordosis. You should definitely make sure you don't lose any segmental lordosis. But capability of introducing additional lordosis is quite limited due to anatomical constraints. So it's an excellent technique in a normal pelvic or a limited pelvic incidence. Thank you.
Thanks a lot, Bart, for this nice presentation. And now we move to the second speaker. We already seen Professor Claudius Thome, Head of Department Neurosurgery in Innsbruck, in Austria. And so he will talk about what is the best solution for patients with high pelvic incidence in terms of interbody fusion. Please, Claudius.
Thanks, Enrico. Again, thanks the organizers. It's always great to be involved with the Brazilian society, and particularly also from an ENS side. As you all know, my heart is with the ENS. So I was asked to talk about pelvic incidence in interbody fusion and the solution for the high pelvic incident patient. There are some disclosures that should not matter. I'll quickly show them to you. But and also I'd like to thank Bart for his presentation. Some of it will be a little bit comparable to mine because I also talk a little bit about TLIF, obviously. So historically, before all the new technology came on, we were doing posterolateral fusions, maybe not even with screws. And obviously this did not have any effect on sagittal balance, at least no beneficial effect, because it was more or less an in situ fusion. Interbody fusion was then developed, and you all know this is based on an interbody device in pedicle screws, and the options that we have are P-lifts, which nowadays are quite rarely used, I find, A-lift from the front, T-lift as Bart nicely alluded to, and then X-lift, L-lift, or O-lift, however you want to call it, from a lateral or an anterolateral approach. The spinopelvic parameters have been introduced, so I can quickly skip this. If you do have a high pelvic incidence, the patient group I was supposed to talk about, the high pelvic incident patient, he does have a high lumbar lordosis, and we all know that most of this happens at the L4-5, and L5 is one level. About 2/3 of our lumbar lordosis are located there. And the iatrogenic flat back, which we have seen over many years in the past, is something that we try to avoid nowadays. So the resolution types have already been shown, and I would like to focus on this type where you have a high pelvic incidence and a high lumbar lordosis, and what kind of interbody fusion is applicable to these patients. What's the evidence? It's always good to look in the literature. And if you look at an open TLIF, this is a paper that was just published a year ago, and they looked at a pretty large number of patients and the spinopelvic parameters before and after a regular TLIF. And what was interesting to see there, that actually they found that they had lost lumbar lordosis on the regular TLIF, and they had worsened SVA. And they've also nicely shown that if you have pelvic parameters and they are poor, this will affect outcome negatively. If they are good, it will affect outcome positively. And as Bart has shown you, if you do a TLIF not with a perfect emphasis on restoring lordosis, you actually lose lordosis, and this is what we have done for many years. Interestingly, this study also showed that patients with a low pelvic incidence, and if they had a loss of lumbar lordosis, they had a very poor outcome. Interestingly, patients with a high pelvic incidence, there was no correlation of outcome after 5 years with lumbar lordosis or segmental lordosis. So we have to say that in a high pelvic incident patient and monosegmental or bisegmental fusion, those patients are mostly undercorrected. So we don't do a good job, but in many of them, it doesn't make a difference because they have much more compensatory capacity because they can rotate their spine more. And so other factors become more important. This is just to keep in mind. If you do a single level fusion in a high pelvic incident patient, that patient may well compensate the non-balanced way you put him. Also, the literature out there is very contradictory, I would say. This is a paper published last year in the Asian Spine Journal. And what they found is that actually a regular TLIF lost 5 degrees of lumbar lordosis, and an MIS TLIF did actually win 1 degree, which is not much, but they actually showed that MIS TLIF was better than open TLIF. And this is a study from the US. I just would like to show you because they used expandable cages and minimal invasive technique, and they could show that they would actually, these are the white bars on the right, they would change the angle in the segment by up to 8 degrees. So they gained 8 degrees of lordosis, which did not impact overall lumbar lordosis. So they didn't correct the overall lumbar lordosis, even though they did a fantastic job to do this, to come from here to there. In an MIS fusion, to be honest, I don't really see that happening, but they obviously managed to do that. Another paper looking at expandable cages, they found the opposite as the other group. They found that if you did change segmental lordosis significantly, this had an impact on lumbar lordosis. And they also found that patients with an initial low lumbar lordosis, you got more correction, and in high lumbar lordosis, and this is the patient group with the high pelvic incidence, they were undercorrected. And they summed up that only in the 2-level patients, actually you had an significant increase in lumbar lordosis. So obviously, even expandable cages may not be good enough. And to be honest, from my experience with expandable cages, I have to agree with this. This is a study just published online, and the title already tells you everything. Expandable cages increase the risk of intraoperative subsidence, but do not improve perioperative outcomes because they have high subsidence rates and loss of correction. And this is also true, which was found by this just recently published article in 2021, that expandable cages may initially restore disc height better than static cages, but most of them subside. And if you haven't really freed the segment and mobilized the segment before, an expandable cage will not do that for you. So this is something we have to be aware of, that those expandable cages don't change anything other than you can put them in through a small hole and expand them on the other side, but they will not mobilize the segment. Now coming to the different options for fusion, if you look at lateral fusions, it's quite clear that lateral fusions have more gain in lumbar lordosis, even though 5 versus 2.5 is not that much. And if you look at OLIF and TLIF, this basically shows you the same, that you can gain more lumbar lordosis if you do an OLIF or a lateral approach. But this study on the right, looking at the same comparison of OLIF versus TLIF, what I found quite questionable is that in the OLIF group, the segmental lordosis increased by only 4 degrees, whereas overall lumbar lordosis increased by 11, which doesn't make sense to me. That why would a 4-level increase at 1 level then add the change the overall lumbar lordosis? So many results out there are at least questionable. Looking at ALIF, ALIF has clearly been shown to gain on average about 10 degrees compared to TLIF, which gains only about 3 degrees in a general way of looking at this. And this was shown that the ALIF group by several groups showed a greater improvement of segmental lordosis. But again, even with ALIF, there was no difference noted in overall lumbar lordosis and PI lumbar lordosis mismatch. Coming to this, Richard Asaka's group, they compared patients with low, medium, or high pelvic incidence, the green bars, and looking at an effect of ALIF and lateral fusions. The only thing they found was that if you use an ALIF approach, you had a more harmonic lumbar lordosis because you were actually increasing the lumbosacral lordosis. So then this may be of benefit, but the overall lumbar lordosis is not affected much by a single or even a bisegmental fusion. This is the paper I probably like best because it compares segmental lordosis and lumbar lordosis for ALIF, LIF, TLIF, and posterolateral fusions. And you see there is a high impact of ALIF and a lower impact of lateral fusions. Interestingly, lumbar lordosis altogether was increased most by the lateral approach. And again, the mismatch was only improved in the ALIF group and not much in the other groups. No big differences between LIF and TLIF. They found that lordotic cages were effective in increasing lumbar lordosis. It may be that they may just use lordotic cages for patients that needed more lordosis, where they were more aggressive, because this study showed what also Bart has told you, that the lordotic angle of the cage did not have an effect on segmental lordosis. And interestingly, what they have published, that the anterior position of the cage was the only factor that was associated with segmental lordosis gain. So very important anterior position. To finish up with the evidence, this is a study from Ulf Liljenqvist's group, a good friend of mine who does great work. And here you see for monosegmental, pelvic incidence lumbar lordosis mismatch, no mismatch, mild mismatch, high mismatch, before and after surgery, and they were able to nicely realign the spine and correct the mismatch by a regular open TLIF, but they used Smith-Pearson osteotomies for most of their patients. So a single TLIF may not be enough. But as I told you, there are somewhat conflicting results depending on the individual technique, and this will obviously not be possible with a small MIS TLIF. So in summary, the take-home message is interbody fusion in the high pelvic incident patients We do know the patients with the high pelvic incidence need excessive lumbar lordosis, but they do have more compensatory mechanisms, so it may actually be not that problematic. Single level lumbar interbody fusion has a minor impact on global alignment. Obviously, you should not lose lordosis. This would be detrimental, but it may not be that important to gain segmental lordosis for the single level cases. It's very clear that lordosis is restored best by ALIF, followed by a lateral or anterolateral approach, followed by open TLIF, and MIS TLIF, or obviously PLIF, has the least effect. Be aware of additional factors. Anterior cage location seems to be very important. Expandable cages, not really. Segmental mobilization is crucial. And if you add a Smith-Peterson osteotomy with a TLIF, this obviously has a great effect on your sagittal alignment. So how I do it, I check for malalignment preoperatively in all my patients. I worry primarily about L4, 5, and 5S1. I don't worry much about the upper lumbar spine usually. The more lordosis, the better, as already Bart pointed out. If I have an L5S1 patient with high pelvic incidence, like this case here, I would opt for an ALIF to restore lordosis. If I would have an L4-5 case, to be honest, if I want to restore lordosis best, I consider TLIF and Smith-Peterson osteotomy, so an open TLIF. For the higher levels and also for L4-5, a lateral approach or an OLIF approach is a very good idea if you need to restore segmental lordosis. So this is what I would usually do, and I'm happy to take any questions, and thank you again for being involved with this. And hope to see you live in person in the future.
Thanks a lot, Claudius.
Wait, Enrico, we have like
yes.
5-6 minutes for discussion.
Okay, great. So thanks both of you for this nice presentation. And before leaving the words to Alessio, my co-moderator, I have one comment on the Claudius speech, and there is no question from the audience. That's why I go on with comments. So I fully agree with you that the expandable technology is not yet the perfect solution. I do implant expandable technology since now almost 1 year, and especially for those cages with a smaller footprint inserted by TLIF, I did observe quite a few rate of immediate post-op or intraoperative subsidence. So my suggestion would be, if you choose for expandable technology, you should try to insert the larger footprint you can in order to cover as much as possible our end plates, and trying to avoid forcing on the end plates too much, because subsidence then is a big reason for recurrence of pain. And I also do have a question to both of you concerning the technique of the TLIF, the open TLIF. Do you always perform the SPO? I liked your point in L5, L4S1, where you quite often associated the SPO to the TLIF. That's what I do in order to have a big pivot point with the cage in the anterior part and then close on a SPO. Do you both do the same?
If I can start, it depends if I really need to realign the spine. In a patient that has a good lordosis and I'm not worried about it, I may do an MIS TLIF, or I may not worry about it. But in those patients that have lost their lordosis at L4-5 and I want to regain it, to be honest, our standard procedure is to do a bilateral open SPO. And really try to, sometimes I even open the disc on both sides, because if you have done your SPO, it's a 2-minute thing to go in the disc and just open it up on that side as well. So I may actually do 2 TLIF approaches on either side to really get nice opening and then nice realignment.
Bart?
I agree. So TLIF has an enormous versatility, and certainly if you do it bilateral, and in many cases we will go bilateral and decompress, and then it's an easy add-on to do that. I agree with that. However, like in older patients with who very often still have a good lordosis and have a normal functionality, no back pain whatsoever, and it's just a decompression of nerve roots and a foraminal stenosis, for instance, and degenerative anthrolisthesis, I wouldn't mind too much, and I'm quite intuitive rather, and I would not really go after the angles.
Thanks. Alessio, do you have any comments?
Yes, I think this is an important issue. Like if you do the TLIF, doing the facetectomy probably is the big point in the technique to increase lordosis, not only the going anteriorly, but also the bilateral facetectomy. So whether you go open or transmuscular, doing the facetectomy, I consider it the big thing to gain lordosis with the TLIF. I think one discussion that we're considering that is that if you really consider the case like a deformity case and you really need to gain lordosis, or if you just need to decompress and reduce and stabilize, because many studies are showing that the mismatch in the elderly, if they don't have so much a high pelvic index incidence, it may be not so important to gain a lot of lordosis. So I really appreciate the presentation. I would like to hear about from you what the importance you really give to restore lordosis in a patient that doesn't have a really severe deformity in elderly patients. Did you understand the question?
Well, if patients...
Claudius, I'm sorry, very quick answer, please.
Yeah, if patients don't have a true alignment problem, I agree with you, I don't worry that much about it. Then I'm more worried about adjacent segment disease. I'm more worried about the risk factors for adjacent segment disease, like laminectomy or violating the neighboring facet joint. And then I'm more worried about this than alignment. I agree with you.
Perfect. Dr. Depeche?
Yeah, exactly the same. If deformity is not really the problem, I'm not so adamant about it. The main thing is not to lose any lordosis, but not necessarily go after additional angles.
Okay. Thank you a lot. Any comments to the story? So we can close.
Oh, that's okay. And we need to close the session. Thanks a lot.
Thank you a lot.
Thank you, moderators. Thank you very much. So we go to the commercials. We'll be back in 5 minutes. Thank you. Hello, we are back from after a short commercial break. And I would like really for participants to make questions. Now it's a time to push against the wall the professors. And we are going to our first crossfire. It's really a very typical clinical case scenario, which is the older patient with a central foraminal stenosis and with a little of segmental scoliosis. So what you want to be quick, do a very efficient operation. You take care with the decompression alone, or you deal with the alignment problems. For this event, this crossfire, Bart will be moderating, and we have two very British surgeons, Andreas and Marcel Ivanov, and as well as Marcus from Brazil. Bart, please.
Okay, thank you, and I want to use the opportunity again to thank you for involving the EANS in this wonderful meeting. And I'm honored to introduce Andreas Dimitriadis from Edinburgh. He is the president-elect of the EANS, and he will talk on lateral indirect decompression and scoliosis correction. Andreas, please.
Thank you, Bart. A big thank you to the organizers from Scotland and the Brazilian Spine Society, specifically to Ricardo Botelho, and of course, Oscar Alves and John Duff, who put this together. We look forward to strengthen collaboration with the EANS. So I've only got 10 minutes. Let's get into this. What is the role of lateral indirect decompression and scoliosis correction was the question posed to me. But that specifically means, what is the role of lateral indirect decompression and scoliosis correction in the elderly with segmental scoliosis plus central and or foraminal stenosis? So not an easy question. However, I will not show you my best case. I will go through the thinking that I use in these cases. I have no conflicts of interest. I will try and cover a little bit of what the size of the problem is, what the options are, pros and cons, any predictors, any conclusions. And effectively, we know that the prevalence of scoliosis in the adult population is widely reported, anything from only 2% to 32%. This is in adults. But studies of elderly volunteers have shown that this can be up to 60%. And the prevalence of degenerative scoliosis per se can also range from 60 to 68%. We do have an increasingly elderly population, and we do have healthcare concerns in these patients who present with significant pain and progressive disability. But the problem is multifaceted, and this is a diagnosis with all sorts of challenges. Elderly in itself is a definition that varies from place to place. They do come with comorbidities, including osteoporosis, which poses challenges surgically. They do have chronic symptoms, which means the expectation management is relevant. They do have high rates of complications. Even in the best hands, there's rates up to 40% reported. There are many techniques on how to address this, which means there is not one ideal technique. And most importantly, the level of evidence is poor because high-level and high-quality trials are lacking, and they're compromised by the heterogeneity of the treatment options. What are the options? Always option one is conservative management. Then if we're going to operate, the traditional option, which is also my favorite option, is a posterior access. There is the option of doing a decompression alone that can be open or minimally invasive, or in fact endoscopic. There is the option of adding in a fusion, which can be a short fusion, it can be a long fusion, or it can be a non-instrumented fusion versus an instrumented fusion. And then we come to the huge variety of options from the lateral and anterolateral point of view, with all sorts of lifts, O-lift, D-lift, X-lift, L-lift, and of course a combination of those. Why would one consider an indirect decompression via lateral approach in an elderly patient? Some of the proposed advantages is the avoidance of morbidity, of post-laminectomy instability. the avoidance of complications from extensive posterior approaches, including the avoidance of muscle damage of the multifidus, which of course can be balanced against the transpsoas axis. There is reduced postoperative pain. There is reduced operative time in experienced hands. There is reduced scarring near the neural elements, and allegedly reduced length of stay in hospital, depending on the extent of the procedure. So how good? Instead of me showing you one great case or even 100 cases, let's look at actual evidence. How good is the lateral approach for foraminal or central stenosis? And I'll start with this systematic review, which I think is of very good quality. It's only a few years old now, but it included over 1,000 patients. And the data did, if we look at the bottom where I tried to put a red marker, the synthesized data has shown that there is evidence of positive effect of the indirect decompression in the lateral foraminal, sorry, in the lateral recess, and therefore the foraminal effects as well. But the evidence against central indirect decompression was lacking. And this is, I guess, relevant depending on what patient symptoms we have in front of us. Again, most importantly, at the last sentence, most studies are limited by study design, sample size, and potential conflicts of interest. Now, this is thrown in many times, but this is very important. The conflicts of interest are varied. We won't go into them, but they have ethical implications. Another good study from the Hospital for Special Surgery, again, similarly found that a synthesized analysis of over almost 2,500 patients. They found that the lateral axis approach was efficient for indirect neural decompression, effective for symmetrical foraminal decompression, and again, they were unclear as to the benefit for central decompression. I'll show you one more, and this is a recent paper, indirect decompression failure after lateral lumbar interbody fusion. What is the evidence for indirect failure? Because this is important. We need to start asking ourselves, what are the predictive factors to choose or not choose a lateral approach? And the report here is of approximately 10% failure rate. They think this is actually underreported or misinterpreted as a complication. And I guess it throws further question marks as to the selection criteria for which is the ideal patient for an indirect decompression in scoliosis. Can we predict when a lateral approach will not be enough for scoliosis with foraminal stenosis? Well, through the literature, I found the few following risk factors. If it's central canal stenosis, a lateral approach is less likely to be successful in comparison to a foraminal or lateral recess stenosis. If there is significant facet joint hypertrophy, facet joint degeneration, and immobility of the facets, again, the lateral indirect decompression may not be as effective. If there are osteophytes in the lateral recesses or the foramen, or if there's calcification of the discs, again, the distraction indirectly might not be as effective. And similarly, if there are osteophytes arising from the posterior end plate. So to wrap up, lateral surgery can be an adjunct to deformity correction, and lateral axis surgery can provide indirect decompression. This seems more effective in foraminal rather than central stenosis, but there is an indirect decompression failure of about 9 to 10%, and this is with accepting and underreporting. However, we must be aware that high-level evidence is lacking, There is a huge heterogeneity of studies. There is heterogeneity of combined approaches. In other words, what people combine together. The permutations are several. The selection bias is real. And while the volume of surgery of this kind is increasing, with pressure from the industry, we still need well-designed studies, I would say rather urgently, so that the spinal community can maintain the advocacy for its patients. In my opinion, the jury is still out for the specific question of indirect decompression for central stenosis and lateral stenosis. So thank you for your time, and I look forward to seeing you in Hamburg later this year.
Thank you, Andreas. You addressed many relevant topics, and thank you for staying nicely within time. I think the questions and discussion will come at the end. So let us switch to Marcel Ivanov from Sheffield. Marcel is a very nice colleague from the EANS Spine Section Board, and he will talk on extended laminectomy and instrumented fusion. Please, Marcel.
Thank you, Bart. Dear colleagues and friends, first of all, it is very sad for not being able to see your faces. And I would like to thank you for having me here and inviting me to talk on this topic, which is quite controversial despite numerous publications we have over the last few years. And my role is to try to convince you that wide decompression and instrumented fusion potentially remains preferred option for a patient with which was described previously. And before I go ahead, I would like to quote one of my friends from Moscow who defines happiness as, so he says that happiness is when you're free and everything around you is stable. So it very much applies to the spine. If the nerve root is free and the spine is stable, probably the patient will be happy. The problem is that with aging, most of us will have some degenerative changes in the spine, loss of disc head. And what is important to understand and to remember is that this segment in some patients is very, very loose, and in other patients, it is very stiff because of these degenerative changes. And this what will have an impact on how we treat these patients. And I think there is no doubt that in lumbar spinal stenosis with spondylolisthesis, the surgical management is better than non-surgical options. It's been shown by sports trials several years ago, and several other studies confirm this similar findings. But and this is just one of the studies which was published just a few months ago in Spine. But in spite of remarkable number of these published studies, the optimal treatment strategy for this group of patients is still very controversial and debated. And unlike many cranial procedures, in spinal surgery, sometimes you'll have as many surgical options as many surgeons you will ask. But we can group this in three main groups, principal groups. One is this wide open decompression with or without stabilization. The other group is indirect decompression, when we assume that by sticking the cage between the vertebral bodies, we can cause some stretching of the ligaments, and by this creating some more room around the nerve roots. And the other option is very focal decompression in a targeted area where it is really tight. So, and the key point is that whatever is the pathology we are treating in a spinal patient, it will be a good idea to keep in mind these AO spine principles and consider what impact your surgery will have on the biology of the specific condition, spinal alignment, stability, and function. So we all learned that decompression can be helpful a long time ago. And Herkowitz in 90s published a relatively small studies, but he showed that with the fusion, the patients tend to do better than non-fusion. And subsequently, we had this very elegant, but probably somehow biased guideline update by the team of Daniel Resnick, whom I saw that he is one of the speakers at this meeting. So he described that decompression, with decompression, we can give good chance of improvement of symptoms. But it was felt that the instability which is associated with this with decompression can increase, and that's why this guideline recommended to do fusion. So, and we learned to fuse these patients and provide stability. And until a few years ago, in some countries, up to 90% of patients would have fusion, even if there was no particular instability. But things have changed a lot after a number of publications which showed that you can actually achieve very much similar results with good decompression and not necessarily fusion. And one thing became clear is that we should not fuse routinely, but with one condition: only if this patient has stable spine and only if the surgery doesn't cause any additional instability. So one of the important questions we have is how much decompression is good enough and how much is too much. So this Cochrane review interestingly showed that there is no true difference between laminectomy and less invasive techniques. However, it showed that if midline kind of wide laminectomy is done, that these patients are more likely to develop a destabilization of the spine and high risk of postoperative slippage. And because of this risk of instability, we have to decide in which case the spinal fusion is strongly indicated. So there are various recommendations, and when I have to decide which patient to fuse, I will primarily look at the facet joint, and if we see some effusion in the facet joints, if we see the orientation of the facet joints kind of more parallel, and if I know that I'll have to remove more bone than necessary in order to decompress the foramen, this will help me with deciding whether I need to fuse this patient or not. And this brings us to the reason why we should consider wide decompression. And unlike other techniques, the conventional posterior approach with direct decompression has been used by us for decades, I would say, and we're all very much comfortable with this. So what is important is this veni vidi vici. The important word is vidi. We should be able to see what we are doing, and none of the other options would provide such a good visibility as a standard wide open decompression. It provides a lot of other advantages, like more room for maneuver. It gives you lots of local bone. If you want to achieve fusion in wide decompression, you can get lots of local bone, avoiding taking bone from elsewhere or any artificial bone. And what is important is the outcome of other techniques are at this stage still not proved to be better than the standard decompression plus minus fusion. So now let's look at the indirect decompression. What we want to see in a patient with direct decompression, indirect decompression, is this: distraction of the vertebral bodies and ligamento-taxis. And by this, we would expect more room around the nerve roots. But what frequently happens is that by putting the cage between the vertebral bodies, actually, it gives a bit of better lordosis, as Claudius just showed recently. But by doing this, we may increase compression on the nerve root in the foramina and in the spinal canal. So what is important is to be able to distract the whole segment, not just the vertebral body. So this is happening because, as I mentioned initially, the facet joints could be very stiff in some patients. And if we don't release this facet joint, they will remain stiff and will cause the problem. So this is a classical example: a patient with a degree of foraminal stenosis, degree of lateral stenosis and foraminal stenosis. So she had a T-leaf, which massive cage, looks very nice, but unfortunately she had quite significant deterioration of the symptoms immediately after the surgery. And she had an MRI scan, and despite a big cage, which would expect to do ligamento-taxis, it caused actually worsening of the picture comparing to the pre-op scan. And why this is happening? Because this segment was very calcified, very stiff, so it didn't distract as we would like it to see in such scenario. And although there is a lot of literature that suggests that the outcome of indirect decompression is very much similar to direct decompression, I was not able to identify a good level 1 or 2 evidence. Most of this is level 3 or 4 evidence. And we should not forget that this indirect decompression comes with additional risk, which Andreas mentioned in this paper. So it will be additional risk of psoas muscle weakness, lumbar plexus injury. There is at least 10% of failure, which usually happens because of the stiffness or calcification of the facet joints. And important factor is that this T-leaf, the indirect decompression would be much more challenging to do it in the lower spinal segment, which are most likely to be affected by these degenerative changes of the spine. Now, MIS is a technique which I really like. I think it has a very good place in our routine practice. It can be particularly helpful in elderly patients with comorbidities if it is only a very focal compression. If you have a wide compression with both foraminal compression and spinal canal stenosis, I would have some more limitation with the MIS decompression. And again, MIS is fantastic technique in some selected cases, but it comes with some additional challenges. It is limited visibility. It is less room for maneuvers. It is more challenges dealing with some complications. It's potentially more radiation exposure if you don't have navigation, and so on. There are many other things which you need to consider when doing this. Now, I think the key message is that every patient is different, and without doubt, the MIS decompression and indirect decompression will work for some of them, but open decompression will work for probably most of the patients. It gives some additional benefits, and as I said, there are numerous options are available, but standard open decompression with fusion, when indicated in my opinion, still remains preferred option for majority of spinal surgeons, because basically it allows decompression both of the intraspinal and intraforaminal components, and it can address the several levels simultaneously. So at this moment, there is no strong evidence to support a specific technique. So the key message, you should be able to select and tailor the surgery based on the individual needs of each individual patient. Thank you very much for your attention.
Thank you very much, Marcel. Again, I invite all participants to fire your questions through the chat box, and we will keep them then for the end of this session. And so now I invite Professor Marcus Vinicius Serra from Sao Paulo in Brazil. He is chief neurosurgeon and works in Casa de São de Santos, I hope I pronounce it well, to add one perspective of minimally invasive endoscopic foraminotomy. Please, Dr. Serra.
I think that I'm the first guy that will take class in Portuguese, but I know that everybody will be translated. I'd like to glad Oscar Alves and Ricardo Botelho to invite me to my class. Eu gostaria de começar minha apresentação com uma pergunta em português. Seria errado nesses pacientes apenas comprimir ao invés de fixar esses pacientes? E a gente tenta sempre responder a 3 perguntas quando a gente está pensando num paciente que a gente vai precisar operar. A primeira delas, qual a raiz que está gerando a dor? A segunda, onde está a compressão? E a terceira, que é a mais difícil, qual o jeito mais fácil de descomprimir esse paciente? Para isso, a gente precisa de alguns conceitos de anatomia e de fisiopatologia. A primeira delas é que esse complexo osteoligamentar pode fechar o forame, ou seja, a ponta da SIP, que é a faceta superior da vértebra inferior, associada com o mergulho que o ligamento amarelo faz no forame, pode gerar uma compressão da raiz de saída, tal qual a SAP pode gerar uma compressão do recesso lateral. Usando conceitos de aging spine, o que a gente precisa saber? Primeiro que o diâmetro anteroposterior do canal ele é definido pelo tamanho do pedículo, ou seja, quanto maior for o pedículo, maior vai ser o diâmetro anteroposterior. Quanto menor for esse pedículo, menor vai ser o diâmetro anteroposterior. Outra coisa a ser avaliada é a abertura, a angulação de abertura das lâminas. Por quê? Porque quanto mais próximo ficarem as duas IAPs, mais próxima ficará as duas SAPs. Com isso, a gente pode ter um estreitamento lateral. E não menos importante que isso é a área de secção transversa. Só que aí a gente não está falando só de osso, a gente está falando de osso e de ligamento comprimindo as raízes da cauda equina. Mas o mais importante para a nossa aula é o recesso lateral. Lembrando que os limites do recesso são feitos pela porção posterior do corpo vertebral e pela porção anterior da SAP, da faceta superior da vértebra inferior. Quando a gente fala em aging spine, a gente precisa entender o que fisiopatologicamente acontece. Então, quando a gente fala de escoliose, a gente vai tendo uma diminuição do espaço discal de forma assimétrica. E essa diminuição do espaço discal faz com que o ligamento amarelo, que é um lençol, ele vá se dobrando dentro dele mesmo. E isso associado à anatomia da faceta pode fazer com que nós tenhamos uma compressão do foramen ou uma compressão do recesso lateral. Isso tudo faz com que os nossos pacientes possam adotar uma postura compensatória em relação à dor e que esse paciente acaba tendo um desbalanço tanto coronal quanto sagital. E quais são as variáveis que a gente tem que estudar quando a gente está pensando em descomprimir um paciente? Primeira coisa é a redução do espaço discal, que pode ser assimétrica. Se esse paciente ter uma diminuição do espaço mais de um lado do que do outro, a gente pode ter um fechamento do foramen do lado onde a gente tem essa diminuição do espaço. O ligamento amarelo dobra dentro de si mesmo, e isso gera uma compressão. Mas o mais importante é a faceta, em relação à sua angulação e à sua assimetria. E, em geral, essa estenose foraminal vai acontecer no lado da concavidade da escoliose. Por que a angulação da faceta é tão importante? Porque facetas sagitalizadas estão relacionadas com pedículos mais longos e elas tendem a fechar o forame. E facetas coronais tendem a fechar o recesso lateral e predispõem a listeses laterais. Outra coisa importante a ser falada são as assimetrias da faceta, porque isso gera um mecanismo rotacional, e isso que gera a escoliose degenerativa. Existem várias classificações, como essa proposta pelo Vaccaro, para definir os graus de estenose de canal lombar, onde o mais importante é o agrupamento das raízes. Outra classificação muito importante para a gente avaliar é a classificação de MSU, descrita por Sanroli, que usa a ressonância no sagital em T2 para mostrar a compressão da raiz emergente. E nesses casos do grau 3, a gente tem não só uma compressão em 2 segmentos, mas a gente tem um apagamento geral da gordura, bem como uma deformidade da raiz. Vamos às evidências científicas para sustentar nossa aula. Eu trouxe 3
Marcos, estamos tendo problemas. Marcos, estás-me a ouvir? Acho que há um problema da sua rede. Sim, força agora.
Melhorou?
Não muito,
melhorou?
Marcos. Não muito, Marcos.
Olhando aqui o meu sinal, ele está cheio, viu, Oscar?
Tá bom agora, tá bom agora. Podes continuar. Tá bom.
Melhorou?
Sim.
Então, nesse primeiro trabalho, a gente consegue observar a quantidade de comodidades que esses pacientes podem ter. Só que esse trabalho, ele estratifica de 35 pacientes, apenas 16 pacientes tinham escoliose ativa. Então, quando a gente vai pegar esse trabalho para colocar nessa aula, eles não estratificaram quais pacientes tinham escoliose degenerativa nas análises. Mas uma coisa muito importante é o tempo cirúrgico, em torno de 75 minutos. Todos os 3 trabalhos que eu trouxe para essa aula fazem cirurgias com o paciente acordado. E quando a gente vai analisar a dor no pós-operatório em relação à perna, às costas, ao oistro e ao McNabb, a gente consegue observar uma melhora significativa na dor da perna, mas a gente não observa uma dor tão importante em relação à região lombar. O VAS lombar mantém-se em 2 de forma sustentada. Quando a gente vai avaliar o Oistro Disability Index, a gente observa uma melhora significativa puxado pela melhora da dor na perna. E o McNabb mostrando 91% de melhora na dor desse paciente, com uma taxa de complicação de 5,4%, muito inferior às outras técnicas descritas nesse Crossfire. O segundo trabalho, e talvez o mais citado, é do Dr. Shen, que é de Beijing, na China, em que a gente observa que há uma melhora significativa da dor na perna desses pacientes e no oestre, e que isso acontece de forma sustentada, ou seja, quanto mais a gente progride no acompanhamento, maior é a melhora que esses pacientes apresentam a longo prazo. E esse paciente, e esse autor, faz uma facetectomia ventral. Mas talvez mais esteja de acordo com a nossa aula esse trabalho da O-Spine, feito por um grupo chinês, em que ele estuda o resultado de acordo com o ângulo de Cobb. Então, ele pegou o grupo A e colocou pacientes com 10 a 20 graus de angulação, o grupo B de 20 a 30 e o grupo C com mais de 30 graus de ângulo de Cobb. E o mais importante é isso. Observem vocês que, quando a gente pega o grupo A, o grupo B e o grupo C, o tempo cirúrgico vai aumentando de 1 hora para 1 hora e meia por conta do aumento do ângulo de Cobb. Ou seja, o ângulo de Cobb é algo muito importante na execução da cirurgia. Aqui no Brasil, a gente costuma dar alta para esse tipo de paciente no mesmo dia. Mas observem vocês que nesse trabalho, o tempo de internação desses pacientes é de 1 dia a 1 dia e meio. Quando a gente vai estratificando o trabalho e a gente separa nos grupos, observem vocês que essa linha que está em azul, são dos pacientes do grupo C, a dor lombar ela permanece em torno de 4 durante todo o período de estudo. Em compensação, a dor na perna e o OESTRI vão tendo uma melhora significativa no decorrer do tempo. E o resultado cirúrgico dos pacientes do grupo A e do grupo B são substancialmente melhores do que no grupo C. Em conclusão desse trabalho, eles não recomendam a descompressão endoscópica se o paciente tiver um ângulo de Cobb maior do que 30 graus ou uma listese lateral maior do que 3 milímetros. E qual que é a vantagem da gente fazer uma descompressão endoscópica nesses pacientes? Primeiro, que a gente está tratando o sintoma do paciente. Segundo, que o tempo cirúrgico é menor do que todos os outros. A perda sanguínea é substancialmente menor nos pacientes submetidos à descompressão endoscópica. E a possibilidade de fazer essa cirurgia com o paciente acordado e consciente. Alguns conceitos que são importantes. Essa aqui é uma classificação que divide a compressão em estenoses centrais, do recesso lateral e foraminal. Quando a gente fala de estenose foraminal, a cirurgia que a gente tem que fazer é a retirada da ponta da SIP. Ou seja, a gente tem uma estenose foraminal e essa compressão é tratada com a drilagem da ponta da SAP, desde lateral até medial. E a gente olhando aqui esse caso, a gente consegue observar que toda a ponta da SAP é retirada. Quando a gente fala de estenose do forame e estenose do recesso, a gente já tem que drilar mais para posterior e expor a porção posterior da raiz emergente, da raiz transeunte, como nesse caso. E aí, quem que descreveu isso? Foi um autor japonês chamado Saiho, que escreveu a facetectomia ventral. O que é a facetectomia ventral? Nada mais é do que uma drilagem feita através de uma manobra chamada manobra de downhand, em que a gente vai drilando de anterior para posterior e a gente resseca toda a SIP. Esse caso aqui, por exemplo, a gente tinha uma faceta coronalizada, então foi possível que nós fizéssemos tanto a descompressão do foramen como a descompressão do recesso sem desarticular em nenhum momento a nossa articulação. E quando a gente tem uma estenose foraminal associada a uma estenose central, vem o trabalho que a gente está escrevendo aqui no Brasil, que é o acesso transforaminal para realizar uma descompressão over the top transforaminal. Como a gente pode mostrar aqui nesse caso, em que a gente conseguiu descomprimir tanto a SAP, SIP, quanto uma parte da IAP, que é a faceta inferior da vértebra superior. Esse caso é muito interessante porque no nível de cima, a gente fez essa cirurgia com o paciente acordado, a gente conseguiu fazer uma facetectomia ventral descrita pelo Saiho em L4, L5, e a gente fez a artrectomia ampliada em L5, S1. Agora, esse é o jeito mais fácil da gente descomprimir o recesso lateral? Não, não é. O jeito mais fácil de descomprimir o recesso lateral, essa aqui foi um caso que eu fiz uma descompressão over the top pelo acesso interlaminar, e o jeito mais fácil de descomprimir é fazendo uma descompressão interlaminar. Mas é factível que a gente faça essa descompressão também pelo acesso transforaminal. E quando que a gente usa essa artrectomia ampliada? No paciente pós-artrodese, em que a descompressão feita não foi suficiente. Nos pacientes em que a gente já fez que a gente vai fazer uma descompressão e que a gente já sabe que ele tem uma artrodese fisiológica. E o mais importante é que a gente tem uma compressão lateral e central ao mesmo tempo. E o que é a facetectomia ampliada, a artrectomia ampliada? É quando a gente, fazendo essa manobra do downhand, além da gente drilar toda a SIP, a gente também drila a faceta inferior da vértebra superior, podendo ascender a regiões mais posteriores do canal e descomprimir o outro lado. O mais importante é que a gente saiba o que a gente quer descomprimir. Então, quando a gente tem uma estenose central, o que eu quero descomprimir? O saco dural e a raiz transversa. Quando eu tenho uma compressão no recesso lateral, o que eu quero descomprimir? A raiz transversa. E quando eu tenho uma compressão foraminal, eu quero descomprimir a raiz de saída. Para finalizar minha aula, um caso clínico de um paciente de 72 anos com claudicação neurogênica e uma radiculopatia L4, L5S1. A gente fez essa cirurgia com o paciente acordado. Esse aqui é um vídeo da cirurgia em que a gente começa a cirurgia drilando de caudal para cranial. Observem vocês que a ponta do meu bisel, da minha camisa de trabalho, está encaixada na articulação L5S1 e através dessa manobra aqui do downhand, a gente vai ganhando espaço de anterior para posterior. Só que mais importante que isso é que a gente drilhe também a faceta inferior da vértebra superior, para que a gente chegue numa posição o mais posterior possível e consiga descomprimir a parte mais central do canal. Observem aqui vocês, no vídeo mais para frente, em que a gente chega na parte articular e a gente vai comendo a faceta lateral e depois a gente vai indo para posterior e drilando também a SAP. O que isso faz? Isso faz com que a gente consiga navegar para posterior e realize descompressões centrais como aqui. Ó. Aqui é a ponta do meu bisel, aqui está a porção anterior do ligamento amarelo e aqui está a porção posterior do ligamento amarelo. Observem vocês que a raiz transeunte, a transversing, está aqui embaixo às 6 horas. Portanto, essa gordura que está aparecendo aqui é uma gordura posterior ao saco dural, ou seja, a gente está conseguindo descomprimir o canal central pelo acesso transforaminal. A gente vê muita gente descrevendo a técnica fazendo um under the top. Observem vocês aqui, oh meu Deus, observem vocês aqui nessa imagem. Observe vocês aqui.
Temos que terminar rápido.
O quanto que a gente está posterior e no raio-x em AP, o quanto que a gente está do outro lado. Ou seja, a gente fez um real over the top. Ou seja, no raio-x pós-operatório, a gente drilou a SAP e parte da IAP. E, para concluir, a gente não pode esquecer dos conceitos de balanço sagital e do balanço coronal, mas eu acredito que seja factível que a gente faça a descompressão desde que o paciente esteja acordado. A endoscopia pode ocupar, em alguns casos, um papel primordial no tratamento dessa estenose, desde que a gente não tenha um número de cobre maior do que 30 graus ou uma listese lateral. E em alguns pacientes que a gente consiga evitar, como no caso, em 75% das vezes, uma cirurgia maior, eu acredito que a endoscopia de coluna possa ter um papel muito importante no tratamento desses pacientes. Muito obrigado.
Bart, 5 minutes for discussion, please.
Okay, very good. I believe there were no questions that came in through the chat, or at least
we have question and answers. Jack Tenorio is asking, Marcus, when you have multiple radicular symptoms, how do you proceed? Do you do injections first to see what's the nerve root being involved, and if so, you do in the same procedure?
If you want, I can answer in English, but I have a poor English.
Very quick answer. Very quick.
Okay. No, I never. I usually don't use blocks to improve my clinic. Okay. I examine the patient, and I tried all the time to make the surgery with my clinical exam.
Okay.
I think that's the main important. When I start my presentation with 3 questions, with the root pain, generate pain, what's the compression, and what's the easiest way to decompress, I think that the anamnesis and the physical exam is the most important thing that you have to conclude your treatment.
Okay, it was clear. Bart, can you proceed?
Yes, there was a question also to you, Marcus, whether you would perform an endoscopic decompression if a patient has instability on radiology.
It's very difficult to understand what is the instability, okay? But in the paper of our spine group, they described when you don't know to do the decompression in endoscopic surgery. If you have more than 30 degrees or more than 3 millimeters with lateral diastasis, it's impossible to perform the surgery because the follow-up showed that it's impossible to do. So the criteria of instability, it's very difficult to understand.
Do you perform, oh, excuse me, do you perform dynamic lateral x-ray, so in lateral flexion in those patients?
Yes, yes. I studied my patients with dynamic x-ray, all the patients. And I measure sacral slope, pelvic tilt, all the spinopelvic parameters before that I decide that what I do in the patient.
Okay.
But any question for Marcel and Andreas, please, before we conclude?
I saw no questions in the box. Marcel, can I ask you a question? So you advocated the direct decompression with or without fusion. Now, in elderly patients with comorbidities, etc., do you use any frailty scores or any means to have an objective assessment?
Yes, I think it is very important to look at individual patients. So so basically we'll have if you have 100 patients which need surgery, I'll cherry pick some of them which may need endoscopy or some micro or minimally invasive surgery, because not all of them will be suitable for this, but most of them will be suitable for a wider decompression. The problem is that if you do a wider decompression, then if they have osteoporotic bone, loss of comorbidities, this is a genuinely big surgery for somebody who is age 80. So it is a balance. But with the wide decompression, what I'm trying to say is that you can achieve a much better release of the neural structures, but you have to put it on the scale, the risk of causing some further instability or metalwork failure. But again, you get all the latest 21st century adjuncts which can help you with augmented screws and so on. So yeah, frailty score is not exactly, we'll look at the frailty score, but I'll look at lots of comorbidity factors, as I mentioned, osteoporosis and so on.
Okay, thank you very much. So we are nicely within time, and I think we can conclude this session here. Thank you very much.
Okay, thank you guys. It was really first day of ANS course that was really impressive, very, very good lectures. So just to remind you that we'll be back tomorrow with another section of the ANS course. It will be on cervical spine. So 5 o'clock Brazil time, 8 o'clock London time, 9 o'clock Central European time. We'll be back tomorrow. Thank you.
Thank you, Oscar.
Thank you, Oscar.
Bonalive, substituto ósseo de vidro bioativo S53P4 com efeito bacteriostático de longa duração, proporcionando uma neoformação óssea rápida e adequada. Gentacol, esponja de colágeno hemostática com proteção antibiótica de gentamicina. Gentafoil, película de colágeno antiaderente com proteção antibiótica de gentamicina. Avitus, coletor de osso autólogo e sangue medular minimamente invasivo. Ossis Medical, tecnologia aliada à regeneração.
Okay, guys. Okay, guys. Good night for you all. Very welcome for our dorsal approaches model. We can see here our good friend Andre as well. We will try to moderate this session. And with no further ado, let's listen Dr. Jun Ho Lee from South Korea. Huge experience on this particular topic. Please, can you start your presentation?
Definitely. Thank you, Chairman, for the introduction. This is Lee from Seoul. The topic that I want to address today is about the MIS cervical laminar foraminotomy. I have nothing to disclose. In the historical evolution of the MIS's application in the field of spine surgery, probably the cervical laminar foraminotomy has the longest history. Actually, it dates way back 70 years ago, starting from Dr. Scoville, followed by the Dr. Spaulding. Probably you all know the name of the Dr. Spaulding because you all do the Spaulding test. Take a look at this depiction and illustration dates way back half century ago. It was not so much different from what we are doing currently in terms of the surgical technology, even in the era when there was no MRI was available. This technique was not so paid so much attention to the average surgeons for decades until this first randomized control study was reported by Dr. Sebastian Rutten 12 years ago in the year 2008. So let's take a look at about this stepwise approach for the cervical foraminotomy. You must position the patient in the prone position. And one thing important is that how to decide the skin entry point of this endoscope. You must think that usually the patient has a cervical lordosis, so perpendicular approach is not so desirable. You need some inclination. So usually the proper entry point should be the intersecting point between the two lines, one line that's parallel to the end plate of the upper vertebrae, the other line that's parallel to the margin of the facet joint. So I think you better need some of the rostro-to-caudal inclination to do the proper entry to the level that you want to address instead of perpendicular approach. First thing that upon the insertion of endoscope, you need a three-point identification, which is the junction between lamina and facet, angled by the two adjoining facet joint. And then you proceed on with the hemilaminotomy, and then expose the nerve root in the proximal position. Thing is that you should expose both shoulder and axilla portion. And then you starting resecting the IAP of the upper vertebrae to expose the ventral surface of the SAP. And then you follow the track of the exiting nerve root route and follow the medial aspect of the SAP resection. This is very important until you expose the caudal pedicle, the axilla portion of the exiting nerve root. And then you proceed with the further decompression of foramen to resect off the residual SAP that's lying posterior to the nerve root. Take a look at this video. One with the protrusion on the right side of C5-6, you position the patient on prone, and testing the endoscopy is approaching to the V point, which is very near to the midline, only within 2 to 3 meters away from the midline. Then you proceed on with hemilaminotomy using the high-speed burr drill. And then you undermine the both SAP and IAPSL. You go on to the lateral. Then you identify the exiting nerve route. You can see clearly from the middle to the 6 o'clock directions. Using your dissectors and some retractors, you can demarcate the junction between the exiting nerve root and the tail of the herniation fragments. Upon giving some pressure on the fragment tail of the herniation, it will naturally pops out like that manner. And using your forceps, you can easily take out the pieces. You search for any additional remnant fragment inside there, especially at the axillary portion of the exiting nerve route, and further decompress it in that manner. And then you can see that the axillary portion is well decompressed as well as the shoulder portion. And that's how it looks after the full decompressions. We think we need some of the discussion on the controversy of this technique's efficacy compared to the standard ACDF fusion surgeries. Look at this interesting case from the young male patient suffering from constant right arm pain for years. Actually, this patient has predominant proton in the left side, but she said she was suffering from only right side contralateral arm pain. And the initial surgeon decided for a good posterior cervical laminar foraminotomy. You can see the surgical defect created there a few years ago. Unfortunately, he was being fine for almost a few months, and he had a symptom recurring back again, was under treatment for like a lot of pain intervention following years. And this is how it looks after before he came to my office. See that original surgical defect and decompression was recapped, resealed with a bony growth again, which is called restenosis, and that's occurring his symptom relapse again. Dr. Mike Falloon and his colleague had proceeded with a very good well-analyzed systematic review and meta-analysis in the year 2019. He found 14 eligible references to his meta-analysis at that time. Interestingly, among the 14 eligible references, there's about 5 of them came from my country, and see that the patient suffering from the complication rate after the surgical technique was approximately summarized for 4%. And those who eventually underwent reoperation was 6%, who underwent ACDF standard fusion surgery was about 5%. So approximately 5% or so was the complication rate overall and summarizedly reported in past years after this technique. What about the stability sake? Dr. Deblik, Wisconsin, reported 30 years ago that using his cadaveric experimental model that resecting up to 50%, or if it's only one-sided, or if you're doing bilateral laminar foraminotomy, less than 25% was allowable to maintain the stability after this surgical technique. This is probably related that majority of cervical spine patients is suffering from kyphotic alignment with their weight-bearing axis lying ventral to the cervical spine axis itself. So the posterior column, posterior part of the cervical spine, including ligament flavum, facet joint, lamina, and muscles and ligament attached to it will be in distractive forces and vectors. So if you are manipulating too much on the posterior side, then you have a very high propensity to create surgical instability. Nabil Ibrahim displayed very good his form measurement. He said he measured the distance between the superior border of the posterior body to the lamina at the point of mid-spinous line, mid-laminar line, and at the V point. Another fourth measurement he displayed was the distance between onset process to the medial portion of the facet joint. See, at the upper cervical level, like C2 or C3, you know that the distance will be very high because you have a very weak gap between the superior border of the body to the lamina. But as you go down to the more downward level, like C5, 6, or 7, this distance is getting very creepy and narrower. The important thing is that onset process is usually lying medial to the facet joint in upper cervical level, but as you proceed on to the lower level, like 5, 6, or 6, 7, onset process is lying lateral to the facet joint. So that means that when you're doing simple discectomy for decompression only, this kind of semicircular laminotomy might be enough for the good decompression. But if you're thinking about doing a foraminal stenosis decompression in the subaxial level, you need to go more laterally more facet resection, and even undermining the upper portion of the lower lamina as well. This is very important messages. Bayumi also performed a very good experimental surgery on using one cadaver model, two experimental surgery, one with a big keyhole on the left side exceeding more than 7 millimeters in diameter for the surgical defect, while on the right side he's performed a small keyhole, so that the nerve root exposed, the length of the nerve root exposed will be naturally larger for the left side big keyhole surgery, exceeding up to 7 millimeters, and the axial portion exposure is naturally more higher for the left side big keyhole surgery. But the thing is that if you measure the ratio between the keyhole angle to the vertical hole angle, it's natural common sense that the ratio will be in positive correlation with the amount of nerve root exposed. But that didn't happen. It was indeed negative or no relation. That means that majority of surgeons are doing only medial spinal cord and proximal part root decompression only, instead of going to the lateral for the full foraminal decompression. So his message was that vertical extension is more crucial than horizontal extension. So we need to consider the inferior extension vertically rather than medial lateral widening of the keyhole if you are interested in achieving better good decompression. So my take-home message will be skin incision should be as medial as possible. Identifying the V-point is crucial in the initial step of the surgery. SAP medial resection and complete foraminal tone should be guaranteed for the full wide decompression during this technique. Thank you very much.
Well, thank you very much for a great talk. It's a very good way to look at this so narrow space. How much you can do? I mean, it's a very good work. Thank you very much. Now let's move on now with the C1, C2 dorsal fusion for dent fracture. Herr Dr. Jens Lemberg, please.
Sorry about that.
Okay. Can you start over, please? Yes, thank you.
So, dent fractures are the most common injuries affecting the upper cervical spine in the elderly population. Often, this is after low energy accident. They are associated with a high morbidity and mortality, and we will see them even more in the future due to the demographic aging. If we do compare the odontoid screw versus the C1, C2 arthrodesis, this was looked at in meta-analysis by Wangui, and the conclusion is clear: in elderly patients over 60 years, C1, C2 arthrodesis from posterior has a higher fusion rate in the developing countries as compared to the odontoid screw fixation. We tend to do more and more posterior approaches for dent fractures in the elderly. If you do look at the different techniques for posterior fusion, the classic one is the Galli-Brooks fusion, wiring and bone. The newer one is the Margall technique, which is a transarticular screw from C2 into C1. And the newest one is the C1, C2 posterior fixation, according to Goel and Harms. Goel published it in '94. So this is the first description of the screw positioning from Goel. It's a screw into the lateral mass of C1 and into the pedicle of C2. He used stainless steel screws and plates for, I think, radial fractures. The first report is of 30 cases. He described a 100% union rate no morbidity, no mortality, no instrument fatigue or failure. Great results. In his later publication, he published 160 patients. Again, no neurological, vascular, infective complication, 100% solid fusion. This was mainly in congenital Atlanta axial instability, but also in 28 trauma cases. The first description using polyaxial screws is from Harms and Melchior, and then this technique is also described as the Goel and Harms technique. So he used polyaxial screws, and this is the main difference to the Goel technique. He also has very good results, satisfactory screw placement and reduction in all patients. No complications, no major complications like vertebral arch injury or neurological deterioration. One wound infection was the only complication, and he has also a very good fusion rate with all patients fusion after 1 year. So this is the technique he described. The entrance point for the C1 screw is just below the root of the C1 arch, posterior arch. The entrance point for the C2 screw is the upper lateral quadrant of the lateral mass of C2. The direction of the C1 screw is convergent of about 10 degrees, pointing towards the anterior arch of the C1. And then for the C2 screw, he described a pedicular screw from the lateral mass towards via the pedicle into the anterior part of the body of C2. If we do compare malpositioning or vertebral artery complications, transarticular from the Margall technique versus the C2 pedicular technique, it is very clear that the Margall technique has a higher risk for vertebral artery lesions and for symptomatic screw malplacement. This is also one reason why you should prefer the C1, C2 fusion. If you do want to reduce the risk for vertebral artery injury during the C2 placement, you can also use shorter screws. 14 millimeters is good, and put them into the pars of C2. So avoiding the pedicle, just putting the screws into the pars. In this publication, there is also a construct stability of 100%, as you can see it here. What are the major points for the Harms-Goel technique? We do fix the head in the Memphis clamp. We do use a C-arm, no navigation. The skin incision depends on the obesity of the patient. 6 centimeters normally is enough. Sometimes you need more, a larger crater. Very important is to use cannulated polyaxial screws. You need cannulated screws, and we only put artificial bone grafts as onlay. So this is the construct that I normally use, a polyaxial screw without threads in the neck, and a short 14 millimeter screw for C2. This is a typical case where we use this technique. I tend to put the C1 screw bicortical, always the goal, but I do not achieve it every time. And if the bone quality is not very good, I put the pedicular screw into C2. If the bone quality is better, I tend to put it as a pars or lateral mass screw. This is also a very good point for this fixation. You can also use this technique if you do have not a dense fracture, but also this is also a very good technique for C2 body fractures or pedicular fractures of C2. Then you can just extend the fixation to C3 lateral mass. As in this case, we put on one side, on the non-broken side, also a C2 pars screw, and then on both sides bilateral screws into the lateral mass of C3. The key points are exposure of C1 and C2 to the lateral edge of the lateral mass. It's very important to see the lateral part of the lateral mass. Subperiosteal dissection is very important to avoid bleeding from the venous plexus. If the space between C1 and C2 is very narrow, it is good to drill a little bit of the inferior aspect of the posterior arch root of C1 to give more room for the C2 nerve root and ganglion. Normally I use 30 to 32 millimeters, 3.5 millimeter partially unthreaded screws, so in the neck unthreaded screws into C1, 10 degrees convergent, pointing towards the anterior prominence of C1, and then a 14 millimeters, sometimes 3.5, sometimes 4 millimeter screw into the pars of C2. This is then 10 degrees divergent parallel to the C2, C3 joint. And I do use synthetic bone substitutes in C1 and C2 lamina as onlay only. But with this technique, you can also think of only temporary fixation. This is a paper by Guo from China. They compared 20 patients with fusion and 20 patients with temporary fixation only in dense fractures. And they saw that with regard to pain, neck stiffness, and the neck disability index, the fusion group is inferior to the temporary fixation group, where the screws and rods are removed after 6 months. And also with regard to the short form 36, all values are better in the temporary fixation group. So in conclusion, the C1 lateral mass, C2 pars posterior fixation for odontid fractures has a low complication rate and a high fusion rate, sorry. And this clearly my preferred technique in the elderly patients. Thank you and greetings from Munich.
Well, thank you very much, Dr. Jens. It's a very good overview and that's some nice tips. We are running a little bit late, so let's move quickly to our good friend, Brazilian Portuguese, Oscar Alves. And he will talk about a minimally invasive posterior fusion. Oscar, please.
Osmar, actually it's not me. We swapped the presentation with Nikolai. So I call Nikolai Konovalov.
Okay, thank you.
I saw him already.
Hi, I'm here. Hello.
Hi, Nikolai.
Hello. Yes.
Thank you for being here. I know it's very, very late in Moscow. I appreciate it. Thank you so much.
Thank you very much for inviting me. So my talk will be about intermediate cord tumors. So you can see my screen? Yes, you can see my screen?
Yes, we can.
Excellent. So I'm going to talk about strategy of intermediate cord tumors. Like this. So all you know that intermediate cord tumors are very rare thing, and it's only from 2 to 4% to different authors among all tumors of neurological system, and the most often in intermediate cord tumors are ependymomas, then come astrocytomas, more rare glioblastoma, and cavernous malformation. So according to the literature, if you look at the publications, the number of publications during the last years is growing. What that means that people are putting more attention to this serious problem, and this shows that more surgeons are trying to do these difficult procedures. So most question about treatment of intermediate cord tumors is when to do the surgery, and nowadays what I can say that the position among all the specialists who are doing these procedures, starting that you have to be a little bit more aggressive than the years before. So about the indications, so you need maybe if you see the growing of the tumor, or if you or any symptoms is coming, so it's better to do the surgery at the earliest stage, not waiting for great neurological deficit, because my main message that when is a neurological deficit, your results are worse than when you do the surgery. When there is a very small neurological deficit, then the results are much better. So we have a rather big experience of treatment for intermediate cord tumors, more than 900. It's only the series that we count. I think now it's totally serious in our institute. It's Burdenko Neurosurgical Institute is more than 1,000. And so analyzing our data, analyzing the literature, most important message is that we are now more aggressive in treatment of intermediate cord tumors, and I'll discuss all these positions in different groups, starting with for the beginning for the ependymomas. So there's a lot of literature describing the ependymomas, and the same rule that the results are much better when you do the surgery when there is a neurological deficit is very mild. And if you do the surgery, for example, when the patients whose McCormick score is 3 or 4 or 3, you will not get the good results. The patients more percentage will not work after the surgery. So our numbers of treatment of intermediate cord tumors is based on 384 patients, and surely in ependymomas you can find the border in most of the tumors, but not in the anaplastic astrocytoma ependymomas. So the new way of examination of intermediate cord tumors is tractography, but it really doesn't play a big role in making the strategy of treatment of this pathology. On this video, you can see the typical ependymomas of cervical level, and you can see the steps of the surgery. You're doing midline approach, then you find all the borders. And in this particular case, you can resect the tumor in en bloc. But really in ependymomas, there is no need to resect the tumor in en bloc. You can do debulking and then resect all the tumor. Here you can see the end of the case is totally resection of the tumor, then closing of the spinal cord, and a good neurological result after this surgery. So we use metabolic navigation in ependymomas. It's not. It's mostly the idea of metabolic navigation in ependymomas is not to over resect the tumor. In most of the cases, you can see a quite nice border of the tumor, but in some cases, especially on the poles of the tumor or in front part, there is some strange tissue that you think this is a tumor. And if you over resect it, you can damage motor tracts and get neurological deficit after the surgery. So we can say that metabolic navigation is, especially laser spectroscopy, is an important thing not to over-resect in the ependymomas when there is a gliosis changes in front of the tumor or the pose of the tumor. This is example of treatment of huge ependymoma, which was from the upper cervical level to thoracic level, and I will just first show this movie. And at the end of the surgery, you can see a total resection of this tumor, and then we check all the parts of the tumor with the laser spectroscopy to be sure that we resect all the tumor and leave the tissue which is different and not to resect it. And here you can see MRI control with a total resection of this long ependymoma with nice neurological result. Our strategy in treatment of ependymomas is mostly you have to achieve total resection of the tumor, but you have always balance. If it's a total resection of the tumor is dangerous and you can damage the nervous tissue, then you can leave some part of the tumor. And if you don't achieve total resection, then you have to observe. And if you see the progression of the tumor or growing of the tumor, and then you can go to another surgery or go to radiosurgery. So this is our algorithm or strategy for growing of treating of ependymomas. So here is our results in McCormick scale. And another big group what we have is astrocytomas. Most important thing that in the classification, in nowadays classification of WHO, they split the polycystic astrocytomas from diffuse astrocytomas because it's totally different tumors according to because diffuse tumors, you can't resect them all, but with the polycystic astrocytomas, you can achieve total resection. And I'll go directly to our experiences 180 tumors, and I'll go directly to the algorithm of these tumors, and it's quite difficult. So first of all, if you have a polycystic astrocytoma, you try to achieve total resection, and if you then you have to go to look at your biopsy. Even if it's polycystic astrocytoma, you can have the key 67 more than 10. And if your key 67 is high, then you have to go to the radiotherapy or to chemotherapy, because this tumor, which everybody thinking is benign, can be very aggressive and can grow very fast after the surgery. Surely, if you don't get the total resection, you have to also to go to send the person to the radiotherapy or chemotherapy. And in the case of diffuse tumors, you have resect as much as possible. Surely you have to prevent neurological deficit and try not to damage the spinal cord, and to prevent neurological deficit after the surgery. And if it's high-grade tumors, which is very rare in spinal cord, you need to send the patient directly to chemotherapy or radiotherapy. Or if the low grade, you have to observe, and if you see the growing of the tumor, you can go to another surgery or send also the patient to radiotherapy or chemotherapy. So main idea in treating of astrocytomas is to understand is it polycystic or diffuse, and then to observe the Ki67 during the biopsy, and based on the Ki67, if it's high, you have sent the patient to radiotherapy or chemotherapy. If it's Ki67 is low, you have to observe, and if you see the growing of the tumor, then you have to think about another surgery or another additional therapy. According to hemangioblastomas, the main idea in literature and in our data that the treatment of hemangioblastomas, you need to do I'll go to directly to the algorithm. You need to do angiography before the surgery, and you can also do embolization in big, if the hemangioblastomas is huge, and try to achieve growth total resection in them. But in some cases, if they are symptomatic, you can surely observe them. But in some cases, and the literature also said there is rather nice results we can get now with the radiotherapy, exactly with the stereotactic radiotherapy. According to the cavernous malformation, all the literature and all our data said that if you even have a huge cavernous malformation, there is no neurological deficit, you don't need to treat them, you have to observe. But if you get if you have symptoms, you need to pass to the surgery. So in this example, you can see cavernous malformation, which is located on the front part of spinal cord, and the patient have a bleeding and a serious neurological deficit. So do the surgery. As you can see at the beginning of the surgery, we don't see any lesion. Then we split the spinal cord, go through the spinal cord. Then we see the cavernous malformation. We use intraoperative angiography, but there is no big idea because it's low flow malformation. And when you do the total resection of this malformation, what is interesting in this particular case, you can see this spinal artery at the front. So you can see that when we resect this cavernous malformation, we totally split the spinal cord in two parts and reach the lesion which is in front of the spinal cord. So this is our algorithm. So main principle, if it's a cavernous malformation is asymptomatic, don't treat it. And if you have a bleeding and have symptoms, you need to go to the surgery. And then last option, what I want to say to you, this is the radiosurgery. And in the case of metastatic disease, when we have a metastatic, for example, this is example of lung cancer metastasis. When we know that this is the tumor, this is metastatic lesion in the spinal cord, then radiosurgery is a very, very nice option because, for example, in this case, you can see that you can only radiate the tumor, and then in a couple of the months, the tumor can disappear with very nice neurological results. So thank you for your attention. Thank you.
Well, thank you, Nikolai. It was great. We are running a little bit late. Let's try to have our questions at the end. Let's move quickly to the next topic, which is image-guided surgery. Our good friend Alison will perform this talk.
Thank you, Osmar. Thank you for the organizing committee to inviting me for this meeting, which is mostly an international meeting. Apologize, my fellow presenters. I'm going to switch to Portuguese. Então, eu tenho conflito de interesse com Medtronic, mas não tem nada a ver com navegação. A neuronavegação em cirurgia de coluna, ela tem uma timeline que data desde o século XIX, com o advento com a descoberta dos raios-x, passando para a confecção dos intensificadores de imagem, tomografia computadorizada, tomografia intraoperatória e até agora, nos últimos tempos, o advento da robótica em cirurgia de coluna. Esse assunto tem sido muito estudado e os dados têm sido publicados recentemente em relação a essa técnica, em relação a essa tecnologia na literatura, e aqui a gente vê o número de publicações no PubMed em relação à navegação Image-Guided Spine Surgery. Basicamente, nós temos três tipos de maneira de navegar em cirurgia de coluna. Ou a gente pode adquirir uma imagem de fluoroscopia no intraoperatório e ter uma navegação em duas dimensões. Essa técnica não tem sido muito utilizada, tem sido cada vez mais abandonada. A técnica que utiliza tomografia pré-operatória para navegar computadorizadamente como se faz em neurocirurgias cranianas. E a terceira tipo de técnica é a técnica onde tu fazes a tomografia intraoperatória e consegue fazer a navegação com a imagem obtida com o paciente na posição desejada, né? Aqui eu não posso deixar de comentar uma experiência brasileira com a técnica em relação à navegação baseada em tomografia pré-operatória no grupo de Curitiba do Dr. Luiz Aguiar, publicado em 2015, com bons resultados. Mas em relação a essa técnica de tomografia pré-operatória, em comparação com a técnica de obtenção de imagens intraoperatórias, a técnica com imagem intraoperatória, isto é, usando o arm, por exemplo, ela tem uma precisão melhor. E por que ela tem uma precisão melhor? Ela tem uma precisão melhor porque quando a gente obtém a imagem da tomografia na posição supina e a gente posiciona o paciente da maneira como a gente quer colocar na mesa, algumas vezes há uma modificação no alinhamento vertebral, o que pode acarretar com uma dificuldade de precisão dessa tecnologia, né? Existem diversos tipos de sistema de navegação 3D disponíveis atualmente, e esses são alguns exemplos, mas eles se baseiam em alguns passos que aqui estão documentados. Após o posicionamento do paciente, a gente tem que implantar no paciente, ou no Mayfield, por exemplo, quando é patologia da coluna cervical, um ponto de referência, um reference array, né? Essa referência ela pode ser implantada na estrutura óssea ou também, mais recentemente, pode ser utilizado o Spine Mass Tracker da Medtronic, que é um adesivo que se cola na pele do paciente e não necessitando de uma incisão extra para se colocar um attachment, né, na estrutura óssea e podendo navegar. Se coloca a câmera em posição onde se consiga ler essa câmera pelos instrumentos e pela referência, né, e depois se faz a tomografia intraoperatória. E a beleza dessa tomografia intraoperatória é que quando a tomografia intraoperatória entra, o surgical staff, né, vai para fora da sala, reduzindo assim a zero, né, a irradiação desses pacientes, o que é um benefício dessa técnica de tomografia intraoperatória para a obtenção das imagens. Demora alguns segundos para processar e adquirir as imagens e depois o cirurgião pode começar a cirurgia, né? Sempre antes de começar a cirurgia e durante a cirurgia, se tem que confirmar a acurácia, né, a precisão da navegação, porque ela pode sim falhar, né? O cirurgião que faz a cirurgia navegada, ele tem que ser sensível, né? Ele não pode empurrar o osso ou bater no osso, porque isso pode reduzir a acurácia da navegação. Outra possibilidade é de obtenção de uma tomografia intraoperatória antes de sair da sala cirúrgica, reduzindo assim a chance de retorno à sala cirúrgica para reposicionar parafusos ou para obter melhores descompressões. Existem inúmeras aplicações para navegação em cirurgia de coluna e quanto mais se usa a navegação, mais se identificam aplicações novas, né? Aqui um exemplo de, por exemplo, parafuso pedicle pars em C2, né? Eu acho que quando se faz parafuso cortical lombar é muito interessante de usar navegação, porque a gente não tem aquele tactile feel. Igualmente a gente tem nos parafusos pediculares, né? Então a técnica do cortical bone trajectory fazer com navegação eu acho bem interessante. Existem 3 grandes benefícios teóricos e também relatados na literatura da cirurgia navegada de coluna. O primeiro deles é quando a gente navega, a gente consegue fazer menores incisões, portanto a gente consegue ser menos invasivo. Isso é muito fácil de compreender. O que se tem na literatura é uma busca para verificar se a acurácia da navegação em cirurgia de coluna é melhor do que as técnicas convencionais. Existem inúmeras revisões sistemáticas com meta-análises da literatura, e esse é um exemplo deles. Elas basicamente chegam às mesmas conclusões no que tange à acurácia. A acurácia da navegação baseada na tomografia intraoperatória, ela parece ser um pouco melhor do que nas técnicas convencionais, mas as cirurgias de revisão, né, como são pouco relatadas e também pouco feitas, elas acabam sendo semelhantes entre as diferentes técnicas. Isso é verdade também quando se estuda pacientes especificamente com uma patologia como escoliose idiopática do adolescente, demonstrando uma melhor acurácia da navegação versus a técnica de colocação de parafuso freehand, mas as taxas de complicação, de reoperação, como são pequenas, elas não são identificadas diferenças entre os grupos. Esse é um estudo que a gente fez quando estava na Universidade de Calgary, com um modelo de escoliose idiopática do adolescente navegado versus não navegados. Parafusos eram inseridos por residentes ou fellows em cirurgia de coluna. E a gente olha que a navegação para trainees, né, aparentemente é mais precisa do que a técnica freehand, né? E a terceira e grande último potencial benefício da cirurgia guiada por imagem na coluna é a menor exposição de radiação para o cirurgião que está diariamente exposto a radiação. Isso é um assunto extremamente relevante que também deve ser levado em consideração na adoção dessa tecnologia. Mas se é tão bom assim, por que não se adota em todos os centros, né? Essa pesquisa, por exemplo, com mais de 300 cirurgiões de coluna da América Latina, mostrou que nem 20% deles tinham disponibilidade de utilizar uma tomografia intraoperatória ou navegação. A realidade brasileira vai mais além. Eu obtive esses dados com a Medtronic e atualmente no Brasil, um país desse tamanho continental, nós temos apenas 7 OARMs funcionando e 32 Telstations que poderiam ser utilizadas com a tomografia pré-operatória, mas na maioria dos centros são utilizados para as cirurgias cranianas, né? Então, por que não se adota esse tipo de tecnologia no Brasil? Por que a gente não consegue adotar? E eu acho que a resposta está aqui. Vale a pena um investimento nessa tecnologia para o nosso país, para um país como o nosso? A gente tem alguns dados da literatura, e aqui eu coloco um exemplo canadense. Eles são extremamente organizados no que tange a identificar valor econômico para as tecnologias novas, para a adoção no sistema de saúde deles. Esse trabalho do Nick D é uma tese de mestrado na London School of Business, do mestrado dele. É um trabalho extremamente bem feito, bem escrito, bem delineado, que ele mostra que em grandes centros, isso é, aqui no Canadá, que fazem mais de 254 cirurgias de instrumentação por ano, e obtém 13 cirurgias de revisão, né? Esse valor de aquisição dessa tecnologia, ele é cost saving, né? E em razão de nos Estados Unidos a cirurgia de revisão ser mais cara, o número é menor, o número de cirurgias necessárias para que se justifique a aquisição dessa tecnologia é menor ainda, né? Esse estudo foi replicado no Reino Unido também com resultados semelhantes. A questão é, a gente consegue extrapolar esses resultados para o Brasil numa perspectiva da medicina baseada em valor, né, especificamente em cirurgia de coluna. A gente consegue identificar que os custos da nossa cirurgia no Brasil eles são consideravelmente inferiores, os custos da tecnologia são maiores e tem uma grande diferença entre as fontes pagadoras. Então, respondendo essa minha pergunta, eu não acho que a gente consiga extrapolar isso para o Brasil. A gente precisa de dados robustos brasileiros para indicar, nesse aspecto econômico, a adoção dessa tecnologia. Mas certamente há casos que não interessa muito a economia, são casos que são melhor feitos, na minha opinião, com navegação. Por exemplo, casos onde se quer obter melhor pontos de fixação na coluna cervical. A gente não está muito acostumado a fazer parafuso pedicular subaxial cervical, então a utilização da navegação parece ser um método interessante. Para pacientes que são necessários cirurgias de revisão, por exemplo, esse caso com múltiplas cirurgias, você vê que existe um bloco de osso na coluna toracolombar e ele tem uma fratura logo acima da instrumentação com um tremendo desequilíbrio sagital. É um caso que é necessário colocação de inúmeros implantes para pontos de fixação e osteotomia de subtração pedicular para correção. Nesse caso, onde não consegue enxergar a anatomia direito, é muito importante eu acho primordial a utilização da navegação. O futuro, então, é realidade aumentada em cirurgia de coluna, né? Eu tive a oportunidade de brincar com esse aparelho quando estava em Montreal em 2018, e foi publicado o primeiro caso, agora esse ano, pelo grupo do Molina, um método super interessante, que a gente não precisa olhar para a tela, olha para o próprio paciente, a imagem aparece na nossa frente. Acho que há um grande interesse em robótica em cirurgia de coluna. Eu escrevi esse capítulo em 2015 e de lá para cá muita coisa mudou, principalmente a compra do Maser Robot pela Medtronic, né? As minhas considerações finais, então, em respeito à navegação em cirurgia de coluna, são que é um tema que está crescendo muito rápido. A navegação em cirurgia de coluna é, sim, muito acurada, é muito precisa, mas, sim, ela pode falhar. Então, existe alguma curva de aprendizado. De uma maneira geral, ela parece ser mais precisa do que as técnicas freehand, né, em geral, né, nos grandes dados da literatura, né? A experiência mostra que após o estabelecimento de um fluxo no centro cirúrgico, não aumenta o tempo cirúrgico, não. Um tópico interessante é que eu não sei se o valor econômico da navegação em coluna no Brasil, eu não posso dizer isso com base em dados internacionais, eu acho que nós precisamos de dados brasileiros para discutir isso com as fontes pagadoras e para a adoção dessa tecnologia, né? Mas há certamente casos que, na minha opinião, navegação é uma ferramenta extremamente importante e há muito que se desenvolver em termos tecnológicos para a cirurgia de coluna. Obrigado.
Oh, excellent, excellent. Thank you, Alison. I'm pretty sorry we are really running a bit late, and Praveen is about to take a flight. I don't understand exactly, but probably we will not have time for questions. A very interesting topic, all of them. I will have to ask for our Praveen and the next model start as soon as they can. I think before that, we have just a few minutes for the commercial. I'll let this to our moderators. So Praveen, I think next session is on you.
Can you hear me?
Yes.
I'm going to share my screen. Thank you very much for this very kind invitation. Let's see, share screen. Cannot share screen while other participant is sharing. So I'll wait until this commercial is finished.
Praveen.
Yes.
How are you?
Good. How are you, Asdrubal? Good to see you.
Good to see you, Praveen. We need to have the 5 minutes break for we have the device presentation right now.
Oh, so wonderful. No problem.
Just hold on.
I will stand by.
Osmar is too fast, you know?
Got it. I understand. Osmar, good to see you also, my friend.
Good to see Praveen. Well, they told me Praveen needs to speak now, so I just moved on.
Oh, I was just hoping that we were in time because here in San Francisco, the surgery is still going on. So I have my partner to cover me for a while so I can come give my talk and then I have to go back.
Okay.
But that's okay. We finished this. We finished the break. No problem.
Hello. I want to welcome all participants to the WNS CNS spine section. Today we'll discuss a timely topic named spondylotic myelopathy. I have the pleasure to introduce well-known speakers, Zohar Gogwala from Tufts University School of Medicine in Boston, Vicent Trinellis from Rush University in Chicago, and Praveen Mumanemi from the University of California in San Francisco. I'd like to ask all the participants to write the question in the Q&A comment section, not in the chat. Just tap the Q&A button and place a question and send it. So we should start with Zu. Zu, maybe we let Praveen give the first lecture. What do you think? You are in Rush also? Zoa? Okay, Zo,
Yes.
Could you let Praveen start before you?
Of course, of course.
Okay, Praveen.
Thank you very much. So very kind of you. I had have someone covering me, and I'm going to have to go back to the OR here. But in any case, I would like to share my screen. So let's see, share. Can you see my screen?
Yeah.
Okay, put it in slide mode. Okay, so the lecture that was requested of me is what is the importance of subsidence and pseudoarthrosis in the cervical spine. It is wonderful to see Osmar and Asdrubal and the team there in Brazil. Also my friends, Dr. Gogowala and Dr. Trinellis, amongst many others. And I wish that we were in person, but we're having to stick with this virtual platform right now. I'd like to thank my fellow Dr. Kuzmic and my research coordinator, Josh, for helping put this talk together. I do have some disclosures and funding sources, which are listed here. As far as the problem at hand, let me show you a couple of cases and let's talk about the problem of subsidence and pseudoarthrosis. This is a 61-year-old woman, had a 2-level corpectomy and then an occiput to 6 fusion for myelopathy 2 years ago at another hospital. The problem is this patient is smoking tobacco and she presented with severe neck pain and continued myelopathy. So she has this construct here. And as you can see, the plate has subsided up from C3 towards C2. And the cage, the expandable cage is also subsided here as well. And you can also see dorsally that the screws and rods are loosened. And there's a pseudoarthrosis anteriorly and posteriorly. So here you see that the cage has subsided up towards into C2-3. Was used to be at the bottom of C3, is migrated up into C3 now. And you can see the plate is also subsiding up towards 2, and then the dorsal hardware is all loose at every single level. So when we look at the cross sections, you can see these screws dorsally have migrated into the foramina, and ventrally the cage is starting to kick out the front. So how do we prevent this kind of an issue is really the question here. Why did this happen to this patient? You can also see the patient is kyphotic with C3-4 compression. As she subsided the cage ventrally, she became kyphotic. So we had to do a pretty significant revision here. Anteriorly removed all of the old hardware, did also ACDFs below at 6, 7, 7, 1, where there's foraminal stenosis, and then put a plate and cages on the front. And then dorsally, we also revised all the screws in the back, C2 to T2. But the main issue here in this patient is that she was smoking tobacco, and because of that had pseudoarthrosis followed by some subsidence because of osteopenia. If we look at one more case to illustrate some of these points, this next patient had a C5 to C7 ACDF. She had to screw back out and had dysphagia, and she is a former smoker, but she quit. And she has neck pain now in C3, 4, 5 area above her prior fusion. We look at her films, you can see ventrally the bone has eroded, the cages are basically floating, the plate is almost coming off the front of the spine, and you can see here at C7 the screw is fractured. So this again, another example of subsidence, pseudoarthrosis, and we had to do a revision for this, and this patient has a P. acnes infection. And with the P. acnes infection, all of this hardware can loosen as well. So she had symptoms from other levels. We did anterior and posterior revision for her. And when we have a P. acnes infection, I prefer to use titanium rather than using any PEEK kind of thing. So we revised her anteriorly and posteriorly as well. So let's, in the context of those two cases, let's see why are we having problems with pseudoarthrosis and subsidence. The problems are here. The construct sometimes is too long standalone. So if we do 3 or 4 level ACDF, we're increasing the risk that the bottom level may not fuse. If we use cages or screws, which are too small, that's also potentially a problem. The screw should be 75 to 80% of the depth of the vertebral body. Really short screws, variable angle screws, short variable angle screws are a problem. If the patients are smoking and using nicotine, it inhibits the bone graft from healing. These patients may have osteoporosis. And then finally, when I see like imaging here on the right, I start worrying that this patient has a P. acnes infection because it loosens all the hardware if you have a P. acnes infection. So those are the typical causes of why patients have pseudoarthrosis and subsidence. So if we look at some of the literature, what we can see, this is a paper that I wrote with my partners, and Dr. Tan, who's one of our partners, and Dean Chow, looked at 77 patients with 3-level ACDF here at UCSF. And what we found is that the bottom ACDF level is where the pseudoarthrosis tends to happen. So if we look at 2 years follow-up using radiographic imaging and dynamic x-rays, it's the bottom level that has the problem on these long constructs. And with a 3-level fusion, there was a significant rate of pseudoarthrosis at the bottom level. And if we look at some of the other literature, which is published by other groups, this is the group from Zia's group, I think when he was in Johns Hopkins. And so 4-level ACDF had a very high rate of pseudoarthrosis, higher than the 3-level pseudoarthrosis rate. So standalone, 3-level and 4-level ACDF, especially an osteopenic patient, can end up with pseudoarthrosis. The length of the screws is very important. Dan Rue has done a study where he looked at short screws for ACDF. You want to have your vertebral body screws be at least 75% of the length of the vertebral body in the anterior posterior plane. You start putting screws which are only 50% of the length, and they're variable angle screws. They don't have good fixation. You may end up getting pseudoarthrosis with those. So try to use longer screws if possible when you're doing these multi-level constructs. Smoking is another problem. We looked at smoking in the setting of corpectomy here at UCSF, and we found that if you had using tobacco, either nicotine in the smoking or chewing tobacco or any kind of tobacco nicotine products, that there was an independent risk factor, highly statistically significant for loosening of this hardware. As far as corpectomies, you can do 1-level corpectomy standalone in the front. You can do 2-level corpectomy standalone in the front. If you do more than 2 levels of corpectomy, you should probably do dorsal surgery because the rate of subsidence and the rate of pseudoarthrosis is quite high. That's work from Rick Sasso back in 2000. So 1 or 2 levels corpectomy with reasonable bone quality, pretty good chance it'll heal. More than 2 levels, probably should do dorsal as well. As far as 2-level corpectomy versus a 3-level discectomy, we looked at this at a study at UCSF. Whether you did 3 ACDFs or you did 2 corpectomies, the pseudoarthrosis rate was not different. So both groups basically had the same pseudoarthrosis rate between 6 and 7% in patients who do not smoke and who do not have osteoporosis. However, we do avoid here 4-level ACDFs. We avoid them because a very high pseudoarthrosis rate, and the level that tends not to heal is the bottom of the levels. What about 3-level corpectomy? 3-level corpectomy, Vaccaro and Sasso both showed that you can have a very high rate of subsidence, pseudoarthrosis, and plate and graft kickout. So 3-level corpectomy, I always will back it up from the back if I have to do that. And I don't trust that to be a standalone. I don't think that's a very strong ventral construct. Osteoporosis is a significant problem. Osteoporosis requires patients to have a modulus of elasticity of their implant to match the modulus of elasticity of their bone. So in an osteoporotic patient, I tend to use more allograft, or I may use PEEK. I tend not to use titanium because it tends to sink through the osteoporotic bone. So we have to match the modulus of elasticity of the bone to the patient. In patients who have severe osteoporosis, T-score is worse than -2 or -2.5. I may give them teriparatide to correct the osteoporosis before doing the operation. So again, consider the modulus of elasticity of the patient's bone compared to the modulus of elasticity of the implant that you're going to use. Titanium is quite stiff. Allograft and PEEK are not so stiff. Osteoporotic patient, you might want to use allograft and steer away from titanium. In a patient with good bone quality, you certainly can use titanium for the interbody construct. So in conclusion, what I can tell you is a few take-home points here. The take-home points are that pseudoarthrosis is avoided by avoiding a 4-level ACDF. I don't do 4-level ACDF standalone in the front. I sometimes will do 3-level ACDF standalone in the front if the patient has good bone quality. I am aware that if I do a 3-level ACDF, the patient should not be smoking. In fact, even 1 and 2-level ACDFs, I ask the patient to quit smoking. We want to maximize the screw length. The screw length should be at least 75% of the AP diameter of the vertebral body. Don't put very short screws, only 50%. Those are associated with higher pseudoarthrosis rate. Have your patients quit smoking before you do cervical surgery for them, and that'll increase their chances of fusing. Optimize their bone mineral density. If they have a T-score that is worse than -2.5, we like to give them teriparatide for a few months before we do surgery. So we will treat them before and after the operation by injecting teriparatide. Match the implant material to the patient's bone density. In an osteopenic patient, better to use allografts or autograft from the iliac crest if you want to harvest it. In an osteoporotic patient, probably I would avoid titanium. If you use expandable interbody cages, make sure you put a lot of bone graft around the cage because there's sometimes those expandable cages have very small lumen, so there's not a lot of bone inside for the fusion to happen. So put the bone inside the cage and outside the cage, or use a cage which has a larger lumen so you can really fill it with a lot of bone. So I think those are my take-home messages, and I would like to thank all of you for your time in listening to this, and be happy to answer any questions. Hopefully I stayed on time. Thank you.
Dr. Asdrubal, pedir para que o senhor... Okay.
Hi, Praveen. So thank you for the lecture. Nice surgery. And I want to go through Zoom to ask him to share your screen and start your lecture. Thank you, Praveen.
Asdrubal, can you see my screen?
Not, I can see you, not your screen.
Okay, just 1 second. We'll do one thing here.
Yep, now I can see.
Great, great. And can you still see it?
Yeah.
Great.
Absolutely.
So thank you, Asdrubal, and thank you for everyone who's been involved in organizing this terrific Brazilian Congress of Spine Surgery. It's a really great honor and pleasure to speak here. While it's a tough act to follow Praveen, who's a good friend, I'll do my best to discuss a randomized controlled trial comparing ventral and dorsal surgery for CSM. We present 2-year results for cervical myelopathy. In terms of disclosure, we have...
Please, Zu,
yes.
Do you mind to have in presentation mode?
Yes.
Yeah.
How is that? Did that work or no?
Not yet.
Not yet. Okay. Just one sec. Let me try one thing. Just give me 1 second here.
Doutor, o senhor pode clicar no canto superior esquerdo para poder iniciar.
Yeah, now it's okay.
Okay.
Great.
Okay, sorry about that, everybody. So we have the funding from NIH and PCORI. We also have private foundation funding, and I have some intellectual property in NIDIS, which is not related to this talk. In terms of acknowledgements, there's a lot of people that work on a randomized controlled trial together. I'd like to acknowledge a few people that were very key in this project: Ed Benzel, Rob Whitmore, Melissa Dunbar, Bob Peary, Bill Butler, Karen Freund, Sandy Schwartz, Fred Barker, Janice Breeze, and Norma Terran, and all of the investigators, including Ashrabal yourself, Praveen, and many others who randomized patients and reviewed cases for this study. In terms of background, cervical myelopathy, cervical spondylotic myelopathy is the leader of spinal cord dysfunction. Surgery is associated with relatively high complication rates in prospective studies, 15 to 18% from the AO studies. Hospital charges are $2 billion a year in the United States. We do in the US 40,000 cases of cervical myelopathy surgery per year. And the optimal approach is not fully established, where in Asia and in Europe, we see more laminoplasty being done for this disease. In North America, we focus on ventral and dorsal fusion surgery. We elected to do a randomized control study to compare ventral and dorsal surgery. We weighted the groups 2 to 3 so that we would have more patients in our dorsal cohort to allow us to compare dorsal laminectomy and fusion and laminoplasty. Our study population were patients aged 45 to 80 with 2 or more levels of stenosis. We excluded patients with segmental kyphotic deformity with kyphosis greater than 5 degrees in extension, structurally significant OPLL, previous surgery, and an ASA score greater than 3. We had previously published the study design and protocol for this study, and in that study design, we wanted to focus on an equipoise population of patients. And we did this by having a panel of 15 surgeons review each case. And so a patient was enrolled in this randomized study if and only if there was equipoise. And this was established by having a greater than 50% vote of experts say that it was ethical to randomize this patient to ventral or dorsal surgery, and also that less than 80% of surgeon experts chose the same approach. So if a vast majority of surgeons felt that one strategy was the best, we would not randomize this patient into the trial. I mentioned that we weighted the trial 2 to 3, ventral to dorsal. We had ventral surgery, multi-level ACDNF or corpectomy. For dorsal surgery, we had laminoplasty or laminectomy and lateral mass fixation. We calculated a sample size with 90% power of 159 patients. We planned to collect patients from 15 major centers and had federal funding to execute and design this study. We defined our aims with a primary outcome looking at 1-year change in SF36 physical component summary score with a pre-specified MCID of 5 points. And we included secondary outcomes, which included these validated outcomes tools that you see here, complications, productivity, return to work, as well as health resource utilization after surgery, radiology, PT, opioid utilization. I have the results to present to you, which were published in JAMA just 1 week ago. So this is new information for many. We collected patients over a 4-year period from 2014 to 2018. 458 patients were screened, 269 were enrolled, 163 randomized. We had 95% follow-up at 1 year and 80% follow-up at 2 years. Our baseline characteristics between the groups treated with ventral surgery, laminectomy infusion, and laminoplasty were all comparable. You can see here the baseline validated patient-reported outcome tools, comparable amongst the groups, as well as, and importantly, the level of stenosis, 2.8 levels in all of the groups. In terms of our primary outcome, as randomized, we saw no difference between patients treated with a ventral surgery versus a dorsal surgery. And I show you this in this graph with individual patient scores represented as a single bar from baseline to their 1-year postoperative score. On the left here, you see the ventral, and on the right, you see the dorsal. However, when you parse out the laminoplasty patients from those patients who are treated with dorsal fusion or with ventral fusion, we saw that laminoplasty patients had superior results at 6 months, 1 year, and at 2 years in terms of our primary outcome measure, SF-36 physical component summary score. Looking at our secondary outcomes, laminoplasty was also associated with fewer complications, 10.7% versus 27% for dorsal fusion and 42% for ventral fusion. There was no significant difference, however, in major complications amongst all groups. A majority of complications in the ventral fusion group were minor dysphagia problems, which resolved typically within 3 months. What about neck pain after surgery? We saw no difference between all 3 of these procedures in neck disability index 3 months, 6 months, and 1 year after surgery. We looked at return to work, and we saw that patients treated with laminoplasty, you see here in this gray bar, had a faster return to work compared with dorsal fusion and with ventral fusion as well. We looked at our health resource utilization, and we saw an increased utilization of diagnostic imaging x-rays in the fusion cohorts. We saw less physical therapy utilization ongoing and less opioid utilization ongoing at 1 year in the patients treated with laminoplasty. We also looked at neurological monitoring. Most of our cases were monitored, but we compared cases monitored versus non-monitored and saw no difference in the major complication rate of 16%. There's limitations to any study, and in this particular study, the promising results for laminoplasty should be interpreted with caution because patients treated with laminoplasty were selected by the treating surgeon amongst patients who were randomized to the dorsal arm of the trial. There is a potential for selection bias, and we feel that a future randomized controlled trial would be important to validate these observations. Nevertheless, we were able to conclude that the CSMS trial is the first randomized control study comparing ventral and dorsal surgery for CMS, showing no difference between ventral and dorsal surgery. As treated in a non-randomized secondary analysis, laminoplasty was associated with fewer complications, less outpatient health resource utilization, and superior 1 year and 2 year health-related quality of life compared with fusion alternatives. Again, I'd like to thank you for the opportunity to present these results at the Brazilian Spine Congress. It's a real honor for me and my colleagues to present at this great meeting. And I'd like to remind all of you of the Spine Summit meeting in the United States in San Diego in July. Thank you again.
Thank you. Thank you, Zulu. And congratulations for the excellent research study that you are conducting. So I would like to ask Vince to share your screen and start your lecture, please.
You got it?
Yeah, yeah, it's okay.
Okay. All right. Well, thanks to all for this opportunity to speak and the late hour for you guys. My assignment is to address sagittal balance and the progression in myelopathy. Here are my disclosures, which shouldn't interfere with it. So we're gonna focus on several things. We're gonna focus on kyphosis, which is really what drives sagittal balance. And I'm gonna talk about global C2 to C7 lordosis, just focal kyphosis, and also another global parameter, the SVA C2 to C7. I'm going to focus on myelopathy, looking at JOA scores, and then disability, looking at neck pain, SF36 scores, and NDIs. And the two are separate. You can have disability without myelopathy, and the reverse is true. And these are the procedures we're going to address then as treatment options. So we'll start with cervical lordosis. It's generally from C2 to C7. It's been our standard for years. There are many papers using this, but I might point out, if you look at the bottom bullet points, that a third of asymptomatic patients may be kyphotic if we use this as our parameter. I also want to remind the audience that with age, lordosis increases. Now this may be skewed. This is the general population. It may not represent those patients that we're treating with cervical spine problems. Now, to get started with the general C2 to C7 lordosis, we look at, these are all relatively recent studies. I'm trying to update the audience. 73 patients, they're looking at cord signal change and related that to global parameters and found that kyphosis from C2 to C7 and another global parameter, C2 to C7 SVA, were both significantly associated with cord signal changes on the T2 weighted MRs. So that's an imaging study. Here's a study that looks at functionality. 118 patients with myelopathy, JOA score significantly related to lordosis and increased SVA. And so we have imaging and clinical backup. But the problem is with all of these studies and many of the things that we have in spine is the correlation factors are a little poor. There's a significant correlation, but it's not applicable to all patients. We need to keep that in mind. So why is kyphosis bad? Well, the cord is tethered against the anterior, it's stretched and tethered over this anterior hump, and this tethering increases intramedullary pressure, which can lead to neuronal loss, demyelination. The anterior vessels are flattened, which can cause some ischemia. And the greater the tension, the greater the intramedullary pressure, and if it reaches a certain point, there'll be apoptosis. So this is the problem with stretching that cord over the anterior hump, even if there's good dorsal CSF space. What about treatment? Well, here's a study looking at 49 patients, dorsal and ventral. And here, the SVA was an independent predictor of improvement in SF36. And unlike Zoe's study, I mean, these are all comers. So some of these patients may have had kyphosis to come in, which would have maybe had the experts knock them out of equipoise. So this is just kind of a general all takers. And the PCS score did not improve if the SVA was over 40. And not only is it global, neurologic problems, but if we look at, here we have uninstrumented fusions, we looked at alignment, JOA, axial neck pain, lordosis, foraminal area, and 23 patients following surgery developed axial neck pain, but it only occurred in those with persistent focal kyphosis. So we have global kyphosis is bad. Here's some indication focal is, and here we have another study looking at focal kyphosis and myelopathy using MR and radiographs. And these investigators found that the sagittal focal angle significantly correlated with myelopathy per JOA score. And actually looking at the standing radiographs, the kyphosis seen on them, it didn't seem to matter. It was what they saw in the MR that really correlated. So that's interesting that we could measure this from a supine imaging study. And does it correlate clinically? It seems to. Here we have a study looking at kyphosis, focal kyphosis treated with corpectomy, a corpectomy discectomy strategy. And the authors concluded that the change in local kyphosis was really the primary driving force and predictor of clinical outcome after their surgery. So If we have focal kyphosis and we can correct that, that seems to be the most viable option. So what are our treatment options? We say global is bad, focal is bad. What about laminectomy infusion? And now we're talking about alignment, nothing more. Almost every study published shows loss of alignment with laminectomy infusion. And I don't know why. I don't know if it's the positioning. When we put the patient, we don't pay attention. I don't know if it's losing that dorsal tension band, but if we look at large groups of patients, they lose alignment. And if we compare anterior posterior decompression with older literature than what Joe Bizot showed, we look at this and we see that if we're looking at lordosis now, so we're measuring a radiograph, we're not doing other studies, but we see that if we go anterior, we can increase lordosis. If we go posterior, we will lose lordosis. So if we're starting with a straight spine, this posterior approach may not be your best advocate. Here's a comparison of anterior decompression infusion to laminoplasty, not laminectomy infusion. Meta-analysis looking at a number of studies, 1,200 patients, and the investigators found better postoperative function, so better improvement in JOA scores with anterior. So that's direct decompression, and we know from the OPLL literature that direct decompression, although more dangerous, is associated with better outcome neurologically, higher recovery rate, and better alignment. So another shot in favor of an anterior approach. Here is a prospectively enrolled study of 171 patients, and we're looking here at ACDF, laminoplasty, and laminectomy infusion, which is a small group. And the investigators found that cervical lordosis and SVA were only preserved by ACDF. And if we look at the data here, CL, cervical lordosis. So if we look at laminoplasty, we lost about a couple degrees, 3 degrees, still significant. Laminectomy infusion, we lost almost half of what was there. And the same with SVA, a loss in both groups. And in the secondary analysis, they looked at JOA recovery and found that lordosis was significantly lower and SVA significantly higher in non-recovery patients. And so what you lose will cost you. And I bring you back to this, especially laminectomy infusion. The loss is the greatest, and that lost lordosis is paying off in poor neurological recovery. Can we predict who's going to lose alignment following procedures? And we all know if we're going to perform a laminoplasty, at least in the US, we want some lordosis. I know in other regions of the world, they will accept a straight spine or a little bit of kyphosis. But even with lordosis, can we predict who might become kyphotic with laminoplasty? And these investigators found it was highly related to the T1 slope. It makes some intuitive sense in that we need more lordosis to overcome that high T1 slope. And so the posterior tension band is at more work. And they found that if there was a change in more than 5 degrees of kyphosis was significantly related to T1 slope. And using an ROC type analysis, determined that the T1 slope cutoff was 29 degrees, which means if your slope was greater than 29 degrees, you were at greater risk to develop kyphosis after laminoplasty. Another prediction of laminoplasty, post-laminoplasty kyphosis is in this publication. And if you just look at the box screen, if we look at the kyphosis, the end case of kyphosis with, if the C2 to C7 lordotic angle is greater than 7, which is a pretty good angle if you measure it regularly, only about 3% of patients develop kyphosis. But if the angle was less than 7, 14%. So it's a 5-fold increase. So you have T1 slope and C2 to C7 angle to help guide your judgment. I know I beat up the posterior approaches a little bit, but here, if we're really aggressive with pedicle screws, these authors, you can do a pretty good approach job with the kyphosis, but it could be a good bit of work and some risk. Just for if you don't want to, if you want to cut cost and not do any fusion, just discectomy. you're going to lose alignment. Laminectomy infusion in select patients that are older that you feel have a very stiff spine. I think if you're going to do a laminectomy, you either do a laminoplasty or laminectomy infusion. But if there's a resource problem and you're very careful in who you choose, if we look at this Swedish population study, we find that you can get away with just a laminectomy. And so in conclusion, it is related to outcome, both neurologic and functional. The best treatment is to correct the focal and global sagittal alignment. And you should try at all costs to avoid laminectomy infusion and only choose that option if for other clinical reasons you feel it's the best choice. And with that, I thank you for your attention and the opportunity to present.
Thank you, Vince. Your lecture was very interesting. And every time that we look the paper, we need to pay attention about which population we are talking about. So we heard the lecture from Zo, and we go from posterior. After I heard your lecture, I go from anterior, but at the end, the kyphosis patient was excluded in Zo. So just remind, it's different population. We are talking different things. Is your comment, Zo?
Zo, are you gonna comment?
Your comment about that?
Well, I totally agree with you that it all boils down to which population you're studying, and as you say, in the study that I described, we purposely excluded patients with kyphosis, feeling that there would not be equipoise to do a posterior approach in those cases.
Thank you. So I'd like to thank you, Zo, Vince, and Praveen that is already in surgery right now. So thank you all. Thank you, the WNS CNS spine section. And if just to remind everybody to go to the spine section. So there we're gonna have more topics related with spondylotic myelopathy. So thank you, Vince. Thank you, Zo. Thank you.
Good night.
Thanks a lot.
Thank you.
Take care.
So now we're gonna have a 5 minutes device presentation. Olá, boa noite. Esse momento é um momento extremamente importante, que é o momento de homenagens de pessoas que deixaram um legado para a cirurgia de coluna e para a neurocirurgia, para a ortopedia e para as pessoas que atendem seus pacientes e colegas. Eu gostaria de chamar o nosso presidente-chefe, o Super Botelho, que ligasse a câmera. Parece que em São Paulo está uma chuva grande, mas eu tenho certeza que ele vai entrar aí com a câmera dele. Está aí o Botelho. E imagino que, Botelho, que nós fazendo essa homenagem ao nosso grande amigo Albert, seria interessante a gente simular ao máximo como se a gente estivesse presente no mesmo local e pedir para as pessoas abrirem as suas câmeras, porque sem olhar nos olhos e fazer uma homenagem, isso é coisa difícil, que eu vou deixar o Albert dizer o nome, mas não é fácil.
Obrigado, Asdrubal. Eu queria falar só uma palavra sobre o Albert. Quando existe um comitê que escolhe os candidatos à homenagem, e por incrível que pareça, nós não temos tido problema, porque os nomes surgem naturalmente, é impressionante. O Albert representa uma geração toda de neurocirurgiões. Se você for procurar uma qualidade do Albert que o leva a estar aqui, é muito difícil achar uma qualidade. O Albert fez vários trabalhos científicos. Eu encontrei alunos do Albert, participei de qualificação, de discussão, que eu depois vim a descobrir que era aluno do Albert, fazendo estudo randomizado sobre vancomicina, estudo randomizado sobre cicatrização e posição, que eu cito para os meus alunos, e às vezes eles nem acreditam que alguém fez esse estudo randomizado e que foi o Albert. E o Albert, nós nos encontramos em várias fases da cirurgia da coluna, várias fases do relacionamento entre os médicos, os produtos, a indústria. E uma das coisas que mais chamou a atenção a vida toda, talvez uma das principais fosse a honestidade. E é um cidadão que passou por todas as fases e se manteve absolutamente sereno, direto, sem desvios. Além da honestidade, também nós vimos o Albert se entusiasmar com palestras das pessoas que estavam começando e prestando imensa atenção e vindo a aprender. E ele já era um grande cirurgião, formador de opinião, formador de pesquisa, e ele conversava com humildade com essas pessoas. Então, o Albert ensinava para nós que a gente precisava voltar para aprender, com entusiasmo e com energia e com humildade. São essas, talvez. Então, eu acho que o Albert, uma das condições que o traz a ser o homenageado é que ele é o Albert. Ele é honesto, firme, corajoso e humilde, e um grande cientista, um grande cirurgião. Eu passo aqui para o Asdrubal, que tem mais propriedade do que eu para falar, mas eu estou muito, talvez emocionado de ter o Albert aqui como. Asdrubal, por favor.
Sim, eu vou fazer o share da minha screen. O Pedro, tu consegue liberar?
Perfeito, doutor. Está liberado.
Tá. Tá aparecendo um Who can share? Who can start sharing? Hein, Pedro?
Ok. Está liberado, doutor. Perfeito.
Deixa. O Pedro, tá, continua.
Asdrubal, apenas clica no botão compartilhar tela ou share screen verde abaixo das câmeras e clica no botão
que já foi.
compartilhar embaixo.
Maravilha, maravilha. Bom, deixa eu só ajeitar aqui. Bom, primeiramente, eu gostaria de dar boa noite a todos. Realmente me sinto lisonjeado a apresentar o meu professor e o grande amigo Albert. Então, aqui eu tenho certeza dessa trajetória de sucesso. Eu vou fazer um pouco mais a parte de demonstrar como que a vida do Albert iniciou e como que ela se sucedeu durante todos esses tempos. Realmente foi uma trajetória de grande sucesso. Relembrando quem é o Albert é um garotão que nasceu em 1956 em Porto Alegre, filho caçula do pai Altino e da mãe Lucy, que tinha como irmãos a Suzane e o Charles, e aí tu vê a família toda ela sentada, e tem uma característica comum dessa família, que é o sorriso, é incrível. Eu tive dificuldade de achar uma foto do Albert não sorrindo. Eu acredito que os caminhos das pessoas já foram traçados muito mesmo antes delas escolherem. E a profissão é ela que escolhe a pessoa que vai trabalhar nela e desempenhar o seu melhor. Então, eu tenho certeza que a neurocirurgia sorriu para o Albert e ele sorriu de volta. E a partir daí não se desgrudaram mais. O Albert graduou-se em medicina pela URGS em 1980, seguiu para a residência em neurocirurgia e, posteriormente, preceptor do serviço de neurocirurgia. Realizou mestrado na URGS, o doutorado pela Unifesp, e quem fez o doutorado se lembra de todas as idas no final de semana, e essas conquistas para ele não foi suficiente. Ele resolveu, em 2006, a fazer a livre docência pela Universidade Federal de Ciências da Saúde de Porto Alegre. Desde a adolescência, ele tinha um encanto pela Júlia e os mesmos selaram esse desejo mútuo de amor, carinho e felicidade no ano de 1990. Esse foi um marco também para todos os residentes e anestesistas do Hospital São José, porque a partir daí o Albert parou de operar de madrugada. Então, não é por nada que tenho ditado que ao lado de um grande homem sempre tem uma grande mulher. Então, eu agradeço muito a Júlia nesse momento, porque a partir desse momento os residentes começaram a respirar mais de madrugada e no final de semana. Do casamento dele, ele teve, junto com a Júlia, a Marina e o caçula Fernando. Aqui na esquerda nós temos o Albert, agachado com uma medalha junto ao filho caçula, o chamado Antônio, que é apaixonado pelo melhor time de futebol. Desculpe aí o chefão Botelho, mas é esse aí mesmo. Na foto do lado, eu tenho o Albert com seus pais, o Altino e a Lucy, o caçula já crescido e a filha Marina. Fernando está agachado e a Renata, que está do lado dele, são os filhos do Albert do casamento anterior. Então, o Albert, uma família bela e, novamente, as principais dádivas dessa família, que é o sorriso. É incrível como isso se vê em todas as imagens. Casamento dos filhos é sempre um grande momento para os pais, ainda mais quando quem casa é a filha do paizão. Então, Renata se casou em 2016 e, nesse ano agora, ela possibilitou ao Albert uma nova experiência, que é ser vovô. Então, aqui a gente mostra o nascimento do filho, Arthur, que recém-nascido, que logo o vovô vai visitar ele nos Estados Unidos. E o Albert realmente tem uma capacidade ímpar de amar, de se dedicar com a família e com a mesma intensidade e importância que dá aos seus serviços da Sociedade Brasileira de Neurocirurgia, aos pacientes e aos colegas. Ele esteve em praticamente todas as comissões da ASBN desde o ano de 1986. Sua dedicação e integridade, coisas que o Botelho falou várias vezes, integridade, honestidade, conhecimento, chamou a atenção de todos os colegas neurocirurgiões. Toda pessoa tem que ter um templo para recarregar suas baterias. Imagino que esses sejam os locais em que o Albert renova a sua energia, a sua casa na praia e o seu iate, vamos chamar iate, fica mais bonito, o iate, E deve ser nesse local realmente que o Albert obtém todas as ideias das suas excelentes palestras e também dos próximos projetos de pesquisa. Mas, sem sombra de dúvida, eu posso afirmar com tranquilidade que nesses locais foram aonde o Albert sempre brilhou, que é no centro cirúrgico e na frente dos microfones. É impecável a sua dedicação ao paciente, sempre com integridade, honestidade, empatia, humildade, que são as qualidades de um grande médico. As suas cirurgias sempre habilmente preparadas, executadas, e 100% unânime entre os cirurgiões que as aulas de elevada qualidade técnica, ele conseguia simplificar e consegue simplificar o que é complexo e permitir uma total compressão do conteúdo. O Albert, além de um grande pai, um grande marido, uma grande pessoa, ele é um professor e um pesquisador nato, organiza cursos, ensina, pesquisa, publica, é o que se espera de uma grande pessoa, de um grande profissional. Sempre foi um importante colaborador desse Congresso, por isso que ele está sentado na mesa do presidente do Congresso, o Ricardo Botelho, juntamente com o Alessio, que é secretário do Departamento de Coluna da SBN, o Bertolini e a Marise, que são coordenadores do Congresso, e o Fernando Dantas, que é membro do Comitê Científico e atualmente vice-presidente da SBN. Então, para sentar nessa mesa tem que ser importante, tem que ser homenageado. Então, a mesa do presidente não é para qualquer um, e o Albert está aí sentado, e realmente com toda a qualificação. Essa foto, realmente a foto lá do Chile, em que o Albert estava fumando charuto e pensando o que eu posso fazer mais na minha vida. Eu posso dizer que, com certeza, não é Botox a tua resposta, tá? Não vai ser isso que tu vai precisar fazer mais, porque os grandes valores de reconhecimento que te tornam uma pessoa importante e famosa são justamente os valores internos que te enriquecem na atitude, personalidade e na alma. E eu coloco aqui esses valores, que são valores que não podem ser comprados, mas sim ensinamentos de berço que foram desenvolvidos e aprimorados durante a tua vida. Eu posso afirmar que cumpriste muito bem o desafio da vida, que é deixar um legado de sucesso, não perante aos teus olhos, mas perante aos olhos dos teus familiares, dos teus colegas, amigos e principalmente dos pacientes. Meus parabéns, e aqui eu falo em nome de todos que estão aí com a câmera aberta, pela pessoa que é, gratidão por tudo que tu está fazendo por nós, pela neurocirurgia e pelos pacientes. Muito obrigado, Albert, e eu gostaria que as pessoas abrissem um pouco o microfone para dar uma salva de palmas para o nosso amigo.
Muito bem, Albert. Parabéns, vida longa.
Parabéns, Albert.
Parabéns, Albert. Parabéns.
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 Parabéns, professor.
Parabéns, Albert.
Albert.
Parabéns.
Parabéns. É uma pessoa bem querida. Albert, agora é contigo. E eu queria saber onde que está a tua mulher.
A minha mulher está sentada aqui na frente e vai documentar esse fato, porque realmente é um momento... Cara, não tem como explicar o que eu estou sentindo, né? Não tem como explicar o que eu estou sentindo. Bom, eu hoje, desde que eu acordei, comecei a fazer a barba, eu já estava faceiro. Eu estou numa felicidade, na verdade, eu estou numa alegria que talvez eu não tenha sentido na minha vida, nessas coisas que a gente anda para lá e para cá. Realmente é um momento de uma grande alegria. E as alegrias, vocês sabem, todo mundo sabe que a alegria só tem graça quando é na frente dos amigos, né? Uma alegria sozinho não tem graça nenhuma. É tão grande alegria que eu estou até tomado pela vaidade, sabe? Que a vaidade é um pecado capital, mas eu não consigo deixar de ficar vaidoso numa situação dessa. Um pouco dessa vaidade é por falha de caráter, obviamente, né? Mas provavelmente o motivo principal para eu estar vaidoso é quando eu olho quem é que está me homenageando. Quem está me homenageando, na verdade, é o Congresso de Cirurgia Espinhal. Cara, quando eu cheguei aqui pela primeira vez, há uns 20 anos atrás, eu estava enfiado dentro de um serviço e eu tinha uma certeza absoluta de que só existia um jeito certo de fazer as coisas e um jeito certo de pensar, que era o meu jeito, o jeito do meu serviço. Quem não concordava com isso ou era burro ou era mal intencionado. Eis que eu acabei chegando no Congresso Brasileiro de Cirurgia Espinhal e acabei me encontrando com pessoas que pensavam diferente de mim, mas que pareciam e revelavam que eram extremamente respeitáveis. E aí eu comecei a entender que as pessoas com quem eu não concordo podem ser objetos de grande admiração. Isso acabou provocando em mim a oportunidade maravilhosa de, muitas vezes, mudar de ideia. Que mudar de ideia é sempre lucro, não é prejuízo, né? Aqui no Congresso, muitas vezes eu me decepcionei com grandes ídolos, quando eu chegava perto dos caras, era uma decepção terrível. Mas, ao mesmo tempo, como tu até citasse, por coincidência antes, eu me encantei com pessoas que eu jamais imaginava que eu ia acabar assistindo, que eu nem sabia quem eram, né? Então, esse tempo todo vivido no Congresso sempre foi uma coisa extremamente intensa para mim. Era intensa dentro das salas de discussão e também, e principalmente, era intenso no corredor, era intenso lá no cafezinho, no lobby do Maxud, no café da manhã, no almoço, nas fofocas, etc. e tal. Na verdade, o Congresso de Cirurgia Espinhal ele é o lugar onde se discute as coisas de cirurgia de coluna no Brasil e que, de alguma forma, ele cria os critérios de respeitabilidade científica que a gente vai seguir no ano subsequente. Ou seja, a gente se encontra, a gente discute e fica mais ou menos estabelecido o que mais ou menos presta, o que mais ou menos não presta, o que se deve buscar. E esse critério ele é construído até o ano seguinte, onde a gente senta e volta a discutir sempre as mesmas coisas, e as coisas vão indo e voltando nesse fluxo eterno do conhecimento que vai para lá e que vai para cá. Essa característica do Congresso de Cirurgia Espinhal, de que as pessoas boas vão chegando, vão se enturmando, participam, e que depois também vão, aos poucos, se afastando e dando espaço para os novos que chegam, né? Então, é por isso que eu estou tomado pela vaidade, porque receber uma homenagem no Congresso de Cirurgia Espinhal é muito importante. Esse negócio de homenagem é um troço meio complicado. Eu já assisti muita homenagem na minha vida e já vi homenagens a pessoas muito nobres e a grandes patifes também, ao mesmo tempo, de forma que a qualidade do
homenageado... É o primeiro grupo, viu? Tu é do primeiro grupo.
A qualidade do homenageado ela varia bastante, mas tem uma coisa que eu observo ao longo de todos esses anos das homenagens que nunca muda. O que nunca muda é o seguinte: sempre que alguém é homenageado, existem na plateia pessoas que, naquele momento, já são maiores do que o homenageado e que já são capazes de oferecer para a comunidade muito mais do que o homenageado já ofereceu ao longo da sua trajetória. É como se o tempo estivesse dobrando a gente e a gente estivesse enxergando a chegada das outras pessoas. É como a gente tivesse que se baixar a cabeça para a vitória inexorável do tempo. Mas a gente não se diminui nessa derrota para o tempo, porque o tempo derrota todos nós. Ele derrotou, derrota e derrotará todas as pessoas, né? O que cabe a mim, então, nesse momento em que, de alguma forma, eu estou no ápice da minha alegria, mas vivendo, de alguma forma, uma derrota? Eu acho que só cabe uma coisa para mim. É entender que, daqui para frente, eu vou continuar como sempre foi. Eu vou continuar sendo respeitado pelas coisas que eu estiver pensando na hora que eu falar aquela coisa. E não vou ser respeitado pelo que eu pensei em 2016 ou em 1994. Não. As pessoas vão continuar aceitando ou não aceitando, e eu vou viver essa curva de progressivamente passar do palco para a plateia com uma alegria muito grande. Para terminar, eu queria dizer para vocês, e fico bem com vontade de chorar, mas tudo bem, vamos em frente, que nós sabemos que nós todos somos apenas elos de uma grande cadeia, de uma grande corrente, e que a gente nunca é um elo muito forte se os elos que estão em volta da gente também não são fortes. Se os elos da nossa corrente não são tão fortes quanto nós não conseguimos nada, nós não temos valor nenhum. E as correntes da minha vida são os meus amigos e a minha família. Então, eu queria dizer que eu quero compartilhar com os meus amigos e com a minha família todos os méritos que, nesse momento, estão sendo dirigidos a mim, porque sem eles, nada disso aconteceria. Tá? Muito obrigado. Vou parar, porque senão eu vou me debulhar aqui. Muito obrigado.
Eu queria, talvez, se o Osmar... nós também estamos muito felizes aqui com a presença do Dr. Elton, e com o Ronald, e com o Vinhal, e com todos. Se alguém quiser falar alguma coisa para o Albert, nem que seja que vai pagar sei lá, um vinho do Porto no próximo congresso, vocês estão à vontade.
Cara, vou contar uma história aqui, que não me leve a mal como paraibano macho, mas eu acho que era o congresso do Léo Dittel, lá em Curitiba, foi a primeira vez que eu conheci Albert. Aí eu olhei para aquele cara, rapaz, que cara bonito, hein? Assim, de clube, chegando assim. Ele chegando e a mulherada toda olhando para ele. Ele já dava uma aula boa, né? Quer dizer, pô, eu quero ser igual esse cara aí. Bacana, com aula boa e o bonitão do pedaço.
Maravilha.
Muito bom.
Foi lá em Curitiba que a gente se conheceu a primeira vez, faz uns 20 anos.
Vinhal.
Isso aí, esse cidadão aí foi tem aquela nossa foto célebre de 2000 no Congresso lá, o Brasileiro de São Paulo, que a gente estava lá sentado lá, o pessoal da coluna, um grupinho de uns 15 pessoas, e é um cara que sempre me inspirou muito. E a gente sempre, desde da maneira como ele apresenta uma aula, como ele apresenta uma ideia. É difícil você não concordar com a ideia no final da aula. Então, você muda muita coisa, e mudou muita coisa na minha vida e no aprendizado de cirurgia de coluna. Um cara que realmente fez a diferença na minha formação, nessa história, nesses últimos 30 anos. Abração aí, viu, Albert? Você merece tudo.
Obrigado.
Eu vi
Vamos ouvir o Osmar
presidentes.
agora, aqui, ó.
Eu vou passar para ele. Deixa eu dizer só uma coisa. Eu vi 2 presidentes da Sociedade Brasileira de Neurocirurgia que se encontraram em situações completamente embaraçosas. Sabe o que eles fizeram para resolver? Levaram o Albert. Então, eu sou testemunho disso. Vamos passar para o Osmar.
Bom, o Albert, a energia acabou aqui na minha casa, na internet. Pode ver que eu estou com vela aqui, ó. Tive que trocar de roupa, tirar a roupa, porque molhou tudo aqui. Mas eu fiz um jeito, eu emprestei o telefone do vizinho, que tem 3G aqui, para eu não poder, eu jamais poderia perder a oportunidade, nenhum egoísmo à parte, eu duvido que alguém tenha tido tamanha influência na trajetória da vida por 2 vezes, como eu tive com você. A primeira, você falou que eu estava louco, né? Falou assim, que eu tinha que procurar um psiquiatra. E era verdade, né? Eu estava num caminho maluco, assim, não vamos entrar no detalhe. E a segunda foi quando eu vi um cara como Mário Tiqueira, que muitos conhecem aqui, um cara retilíneo, impressionante, né? Ele virar e falar assim, não, esse assunto a gente não consegue resolver no meio de um monte desses ícones todos. Faz o seguinte, pergunta para o Albert, porque ele tem aquela capacidade de transformar em transparente um negócio que está completamente anuviado, que está nebuloso, daí ele vai lá, eu não sei como ele vai puxando o fio e, de repente, ele fica inteligível. Se está errado, está certo, é outro assunto. E daí eu comecei a olhar para todas essas coisas e eu vou lembrar de uma que você vai lembrar também, que nós tínhamos todos cabelos, que ainda tinham cabelos pretos, e eu chamei o Geraldo, Dantas, não me lembro de todos, não quero ser injusto, né? Para nos reunirmos em São Paulo, e você é o que estava mais distante, e a última coisa que você falou foi eu vou ter o máximo prazer em participar. O cara pagou a passagem, pagou a estadia, comeu mal, né? Que era ruim o laboratório da beneficência portuguesa, né? E ainda agradeceu. Depois é que eu fui entender. Então, eu vou terminar dizendo uma coisa bem prática, bem objetiva. Todos que estão aqui, em algum momento, você influenciou a vida da gente. E eu vou discordar mais uma vez, né? Acho que a cada 10 anos eu tenho um jeito de discordar de você. Primeiro que eu era maluco, eu não sou não. Parece que eu sou, mas não sou. Você está completamente errado que você está falando de uma derrota. Essa é a vitória da vida. Sabe por quê? Toda vez que alguém fala que a gente está ficando velho, eu falo assim, olha, a alternativa é péssima, né? Porque a alternativa a ficar velho é bom. Cacete. E o velho, que não é nosso caso ainda, ele é o jovem que deu certo. E para nós todos aqui, que estamos aqui meio de plateia com você, essa é a definição de você. Você é o jovem que deu certo. Essa é a verdade. E eu não podia deixar de fazer isso, eu vou ter que devolver o telefone para o vizinho aqui, mas eu não podia falar isso aí.
Osmar,
para todos aí.
Osmar, no próximo ano a gente vai te comprar um telefone com 4G, tá? Eu vou falar com o Botelho, o Congresso vai te dar um telefone para ti, viu?
Tá tudo lá, não tem luz que eu posso fazer, pô.
O Alisson quer falar alguma coisa ou não? Eu não vejo todos aqui. O Alisson quer falar algo?
Eu acho que, bom, o Albert me ensinou tudo que eu sei sobre cirurgia de coluna, mas com certeza isso eu fico chateado. Ele não me ensinou tudo que ele sabe sobre cirurgia de coluna. Acho que a homenagem do professor Asdrubal foi sensacional e as palavras do Albert também foram sensacionais. Professor, parabéns pela homenagem.
Se ninguém mais deseja
eu acho
fazer...
que o Elton tem que falar, viu?
O Elton está aí.
Né? O Elton já foi homenageado também, uma pessoa extremamente jovem, de alto conhecimento. Tudo bem, Elton? Que bom te ver com saúde, te ver feliz, sorrindo.
As palavras aí, e acho que vocês foram muito felizes em escolher o Albert. Albert, meus parabéns, homenagem muito merecida e fico feliz em poder compartilhar esse momento com você e os demais colegas aí. Parabéns, merecido, bem escolhido. Grande abraço.
Todos os jornais hoje citaram Ribeirão Preto do início ao fim, viu, Elton? Você está famoso.
É o Congresso de Endoscopia, Botelho?
Não, é o lockdown.
Olha a situação difícil.
Dá para todos, dá para todos.
Bom, Botelho, tu é o chefe, o presidente. E se alguém mais quiser dar um oi aí, Albert, para mim foi um tesão fazer esse material, viu? Só assim eu te conheci mais. Tem que falar um nome feio. Eu vou ter que falar porque o Albert não fala. Eu tinha apostado com o Botelho que tu ia falar um nome feio e tu não falou.
No final ele fala o nome feio.
Perdi.
Pessoal, eu vou pedir para encerrar esse nosso bloco, para a gente ficar com a emoção e com a alegria. Vou pedir para o Eduardo da TI e o Pedro colocarem a musiquinha. Eu vou dizer por quê. Eu sempre achei que se a gente colocasse todos os produtos e devices num momento só, ia ser ótimo para nós todos. Então, eu vou pedir, com essa emoção, nós vamos encerrar com as tecnologias e devices e ficar com essa energia aqui que o Albert e vocês transferiram a todos nós. Tá bom? Eduardo, entre aí. Um abraço a todos. Mantenham conosco até o encerramento desta sessão e depois a gente continua.
Acho que terminou, né? you.